complex anatomic and clinical settings. Trainees, residents, and fellows will have an ample opportunity of growth and collaboration, one-to-one discussion with their mentors, improve their skills in pediatric heart valve repair, and get insights on how to develop the most effective treatment strategy for their patient with long-term positive outcome. The Karnataka Medical Council designates this hybrid conference a maximum of 4 credit points. Also, this event has been endorsed by Pediatric Cardiology Society of India and Indian Association of Cardiovascular Thoracic Surgeons. To begin with, I invite on stage Dr. A.R. Raghupati, Director Medical Education, SMS IMSR Modanhalli, to please give the keynote address and address this gathering. Thank you, sir.
My pranams at the lotus feet of our Divine Master, Sri Madhusudan Sai. Sairam to you all, good morning. Vaidyo Narayana Hari. This was the first sentence told by my master when I came to this institution, when he gave me the interview. And he told that Vaidyas are Narayanas. And he gave the explanation why I am telling that sentence, and that was a beautiful experience to me. Today I am telling you once again the Vaidyo Narayana Hari. You are the real divine embodiments. Why I am telling you is you are the one who are giving the new life. Yes, God has given the life to the children, unfortunate children who have born with congenital heart disease, but you are the one who are giving them the new life, so that they can see at their 5th birthday. Otherwise, most of the children will not see the 5th birthday. To you all, I bow my head with due respect. I am very happy to see the Pitamaha of pediatric cardiac surgery. Dr. Cherian is here, father of pediatric cardiac surgery. Dr. Kalangos is here. I am very happy, and I invite you all to this August gathering and to the institution, Madhusudan Sai Institute of Medical Sciences and Research. It is really a privilege to receive you here. Today, as we open doors for the first international conference on pediatric heart valve repairs, on behalf of Sri Madhusudan Sai Institute of Medical Sciences and Research, I extend a warm welcome to all Vaidyas present here. Welcome, doctors, to this 2-day scientific program that shall enable you to equip yourself surgically for efficiently facing the evolving scenarios in medical practice. As we assemble here under the roof of Sri Madhusudan Sai Institute of Medical Sciences and Research, let me remind you of the thought behind this monument of selfless service. This medical institution offers free medical services and free medical education so that the patient and the students are relieved of the burdens of financial restraints that today's material world puts forward. Let me give you a small statistics. Our hospital, along with our sister concern hospitals, Sanjay hospitals, we have done more than 30,000 pediatric cardiac surgeries totally free of cost. And since 2 years, we are doing the multi-specialty hospital in Mudanalli, along with cardiac surgeries. We have done more than 8,000 surgeries till today. We have done 4,000 deliveries here. This is what I want to tell you is whatever work is happening in this institution is With two principles, we are doing the work: total selflessness and total compassionate. Compassionate and selfless work is happening here. Welcome to our institution to see that. This institution is a blend of Vedantic knowledge of the East and the technical advancement of the West. It is to this monument selfless service institution I welcome you all to attend the 2-day scientific conference, thereby benefit from it. Thank you. Sairam to you all.
Thank you, Director Sir, for your insightful and motivational speech. Next, I would like to call upon stage the Conference Organizing Secretary, Dr. C.S. Heramat, to present the welcome address and officially commence the event. Dr. C.S. Heramat is a senior cardiac surgeon and senior consultant of our institute. He is the Director, Heart Valve Bank and Academics, CTVS, and Secretary of Indian Association of Cardiovascular Thoracic Surgeons. So.
Sairam, a very good morning to all of you. Offering my reverential pranams at Divine Lotus feet of Bhagwan Sri Satya Sai Baba and Sadhguru Sri Madhusun Sai. As we open the curtains to embrace a 2-day commitment towards empowering professionals with in-depth knowledge, I extend a warm welcome to the diverse congregation of medical experts and participants from across the country and across the world for the first international conference on pediatric heart valve repairs, jointly organized by Sri Madhusun Sai Institute of Medical Sciences and Research and Sri Satya Sai Sarla Memorial Hospital. At the outset, I would like to welcome especially Dr. K.M. Cherian, the doyen and the father of Indian cardiac surgery, who is happy to be amongst us and his family. Dr. Kalangos, who has come all the way from Greece, a very senior, renowned pediatric cardiac surgeon. Dr. Shaun Setty from USA, Dr. Shivaprakash from Malaysia, Dr. KSA, Dr. Suresh Rao, and all of the senior dignitaries who are amongst us here. For sure, our little patients deserve the best, and so we are here to embrace learning through knowledge sharing with the commitment to excellence. There are not just cardiac surgeons around today. We have cardiac anesthetists, cardiologists, intensivists, nurses, students, and even the medical students are here aspiring to be cardiac surgeons amongst us. I would like to extend my thanks and gratitude to the Paediatric Cardiac Society of India, the Executive Committee, and Indian Association of Cardiothoracic and Vascular Surgeons who graciously endorsed this program, and also the Karnataka Medical Council. This conference will feature a range of discussions to give insights on how to develop the most effective treatment for our little patients, starting from valve problems to the advanced techniques. And when valve repair fails, what next is the transplants which we need to do. And we have Dr. K.R. Balakrishnan, who will join shortly with us to deliver his insights also. Before we begin, I would like to extend our heartfelt gratitude to the organizers for this dedicated hard work, which is being ongoing for the last 3 months. And I would like to thank personally for guiding me, Dr. Kalangos, who is the chairman of this conference, and Dr. Shaun Setty, who is the co-chairman for this conference. They have taken quite a lot of efforts to make this program success. Without the guidance, it would not have been possible to what we are today. Without further ado, as we embark on this journey, I encourage active participation, both offline and online delegates. Today evening, we have an inauguration process at 5:45 p.m. in Premamutta Hall, which is just about 500 meters from here. Vehicles will be arranged from outside. We need to be seated there at 5:45 p.m. I had few of the delegates been taken there just now, just to brief them the seating arrangements. I request all of you to kindly cooperate with the timings. We need to wind up the session by 5:15 maximum. Height is arranged after that here outside at Atisha Hall. Subsequently, we move to the Premamutta Hall. Sadhguru Madhusun Sai will be coming, and we have been watched across 60 countries. A YouTube link is there, which will be shared for each of your members so that you can share with your family members who can watch live. And I've requested Sadhguru to see that everybody gets felicitated because the time taken, your precious time coming all the way, and he has graciously agreed to see that he meets each one of us. And with these few remarks, I would like to request Dr. A Kalangos, the chairman of this organizing committee, to speak a few words. Thank you.
Sairam, everybody, distinguished guests, dear colleagues. As you know, pediatric heart valve diseases represent a crucial public health problem, especially in young populated countries like India. For this reason, we have decided to organize this international conference, which covers all the aspects of pediatric heart valves. As you have already noticed, we were able to gather many international and national guest speakers who are experts in this field. I would like to thank all of them for this very valuable contribution. I would like also to thank Dr. Hirmat as well as Dr. Setty, who helped all of us in preparing this extensive program. I wish all of you an interactive and successful 2 days conference. Thank you.
Thank you, Dr. Kalangos. Now, the first session of the day is on mitral valve. Mitral valve repair in children has always been a surgical challenge because of the broad spectrum of the congenital and the acquired lesions that affect the mitral valve, and also because of the small and the immature fragile subvalvular components and the mitral valve leaflets. Nevertheless, mitral valve repair has always been the favored strategy for the construction of the valve in infants, children, and adolescents. So I would like to request the chairpersons for session 1 to kindly come on stage and give their valuable inputs during the session. May I request Dr. K.M. Cherian, Dr. Shaun Setty, Dr. Suresh Rao, Dr. Adarsh Koppula, Dr. Baiju S. Dharan, and Dr. Sanjay Cherian to please come on dais and chair the first session on mitral valve. Dr. Shivaprakash Krishnanaik will be joining us online to chair this session. A detailed understanding of the morphology and the function of the valve is crucial for the fundamental principles of valve repair. Our first speaker needs no introduction. He is a world-renowned clinical anatomist and pathologist, Dr. Robert H. Anderson from UK. He has graciously accepted our invitation and recorded his presentation for us on the topic Demystifying Mitral Valve Complex, an overview of congenital mitral valve malformations.
These presentations, and I'm particularly appreciative of the fact that you're making it possible for me to be with you from my living room. So we're going to be discussing the anatomy and the malformations of all the cardiac valves, starting off with the mitral valve. And what I'm going to try to do throughout my presentation is start off with the relevant anatomic features, In all of the lesions, I'll be discussing the components as part of a complex, and then I'll seek to relate the anatomy of the normal heart to the malformed situation. So let's get started with the mitral valve. And I'm showing you here the arrangements of the valvular complex as you see them echocardiographically in the parasternal long axis orientation. And what we can see here is the so-called annulus. You'll note that I have that in inverted commas, and I will explain why that is the case very shortly. But within these components, we have the leaflets. Throughout my presentations, I'm going to be calling the moving parts, different valves, the leaflets, because I consider the term cusp to be very ambiguous. And again, you'll see the reason for that. So in the mitral valve, the leaflets are supported by the tendinous cords, and in turn, the tendinous cords by the papillary muscles. And these, of course, make up the tension apparatus. And it is the fact that the mitral valve and the tricuspid valve have a tension apparatus that distinguishes them from the arterial valves. So let's now look at those different component parts. And you now see that what many call the annulus, I'm going to call the atrioventricular junction. And it differs in the mitral valve in that the superior part is fibrous. This is the area of aortic to mitral fibrous continuity. The opposing part is muscular. As I will explain, that supports the mural leaflet of the valve. Now, there's marked variation in the support given to the valvular hinges around the junction, which is why I dislike the term annulus. It's very rare to find a complete fibrous ring, and that in turn has created great ambiguity at the moment with the concept of so-called mitral annular disjunction. Now, this is the so-called classical view of the junction, where there is a fibrous cord supporting the leaflets of the mitral valve. But this is far from the usual situation. So in all normal hearts, we find the arrangement such as this, where rather than finding a cord, we find a shelf with separation between the locations of the ventricular and the atrial myocardium. And here you see that separation is well over 2 millimeters. And this is so-called disjunction. But in other parts of the orifice, we find the arrangement where there is nothing but fibroadipose tissue separating the atrial from the ventricular myocardium. So mitral annular disjunction is a very confusing term because the arrangement is part and parcel of the normal arrangement of the mural hinge point. But let's turn our attention to the leaflets. They are best described, in my opinion, as being aortic and mural, reflecting those attachments at the atrioventricular junction. Now, if we open the junction and we look at the valve as seen by the anatomist, then we find that the mural leaflet has an extensive attachment around its circumference, but is relatively shallow. In comparison, the aortic leaflet has a much smaller attachment around the circumference, but is much deeper. Now, you as surgeons, of course, see the leaflet in the closed position. And this is what it looks like when you look down upon it through the left atrium. And its major feature is the solitary zone of apposition. But that does not reach to the atrioventricular junction. So we have these so-called commissural areas. So if we now try to describe the components, we have the primary zone of apposition. At each end of that, the commissural leaflet separating the zone of apposition from the junction. And then we have these slits in the mural leaflet. And that permits us to describe the so-called scallops, of which usually there are 3, and they obviously oppose to comparable components on the aortic leaflet. But this is no more than the usual arrangement, and if you look at any number of mitral valvular leaflets, you will find marked variation in the number of slits in the mural leaflet, as was pointed out long since by Solomon Victor. Now, the leaflets are supported by the tendinous cords. So again, the anatomist's view with the valve open, and to emphasize again that the zone of apposition does not reach to the junction. So we have a little bit of leaflet tissue between the so-called commissural areas, and the so-called commissural cords are attached from papillary muscles such that they support both of leaflets. But over and above that, we have these free edge cords. And the key point of the mitral valve is the leaflets throughout their circumference are usually supported well by the free edge cords. If we look on the aortic aspect of that aortic leaflet, we then find strut cords. And if we pull up the mural leaflet and underneath it, we find the so-called basal cords. And that's as far as I go in defining the leaflet, the tendinous cords supporting the leaflets of the valve. If we now look at the papillary muscles, I'm showing you the heart here as it lies within the chest, and I've removed the parietal wall, and I'm looking at the septal surface from behind. And that shows us clearly that one of the leaflets of the valves is attached to the diaphragmatic surface of the left ventricle, so it's inferior, and it's adjacent to the septum. So we can call this the inferoseptal leaflet. The other leaflet, which is behind the inferior leaflet, is superiorly positioned and lateral. It is a mistake to describe these leaflets as being antero-posterior and postero-inferior. They are inferoseptal and superolateral. As with the overall valve, nowadays its components should be described using attitudinally appropriate terms. So there we have the arrangement of the normal valve. How do we describe its malformations? And we do it in terms of the complex that I've now explained to you. And there can be global involvement. And that involves the annulus, the leaflets, the tendinous cords, and papillary muscles. We see that when the valve itself is hypoplastic, and we see it at its best as part and parcel of the hypoplastic left heart syndrome. So here you can see a very nice example of global involvement of the mitral valvar complex. There is a hypoplastic junction. The leaflets are dysplastic. The tendinous cords are thickened, and that thickening obliterates the intercordal spaces. And then the papillary muscles themselves are fibroelastotic, part and parcel of the fibroelastosis that lines the entirety of the left ventricle when we have the hypoplastic left heart syndrome in the setting of mitral stenosis. And that, in turn, is part of the global involvement of the mitral valvar complex. But the lesions can also exist in isolation. The junction itself can be involved in Ebstein's malformation. Now, you all know Ebstein's malformation usually involves the tricuspid valve, and we'll be looking at that in detail when we get on to discuss the tricuspid valve. But very rarely, Ebstein's malformation can involve the morphologically mitral valve. And then we need to distinguish between that and Ebstein's malformation of the morphologically tricuspid valve in the setting of congenitally corrected transposition. But the mitral valve can be involved in Ebstein's malformation, and here is an example of that lesion. The key point here, the valve leaflet involved is the mural leaflet of the valve. So in this heart, I open the valve from behind, and there you see the aortic leaflet, and the aortic leaflet is in its normal position and is in fibrous continuity with the leaflets of the aortic valve. There is the atrioventricular junction, but the hinge point of the mural leaflet is displaced relative to that morphologic atrioventricular junction, and we see it here tethered within the ventricle along its length. So this is that very rare malformation, Ebstein's malformation of the morphologically mitral valve. So let's move on. And it is the leaflets and tendinous cords that are most frequently involved when the mitral valve itself is malformed. So the valve can be imperforate. We used to think that the atrioventricular junction itself could be absent, but we now think that is no longer the case. So nowadays, when you have mitral atresia, it's because the mitral valve is imperforate. There can be an isolated cleft of the aortic leaflet. As I'm going to show you, we will need to distinguish that from the so-called cleft of the left atrioventricular valve in the setting of atrioventricular septal defect. The mitral valve can straddle an ovoid. It can have dual orifices, and perhaps most importantly and most frequently, its leaflets can prolapse. So let me show you these various malformations of the leaflets. Here is the imperforate valve. And as you see, the imperforate valve is supported by its tension apparatus, and there we see the hypoplastic papillary muscle, in this instance without fibroelastosis, because this is in a heart with deficient ventricular septation. We only see that fibroelastosis when the ventricular septum is intact, as in the hypoplastic left heart syndrome. And that's when we most frequently see the imperforate mitral valve, but I've just shown you an example of when it can be found with concordant atrioventricular connections and a ventricular septal defect. So let's move on and let's look at the isolated cleft. And the isolated cleft involves the aortic leaflet. Here it is, and you see it is attached by a tendinous cord through the ventricular septal defect, because the isolated cleft points into the subaortic outflow tract. And that is the difference from the so-called cleft, which we will be discussing, setting of atrioventricular septal defect. That, of course, is the zone of apposition between the bridging leaflets. So we need to distinguish between the true cleft, as we see here, and the so-called cleft, which is part and parcel of the normal arrangement, the left atrioventricular valve, when we have common atrioventricular junction. The key point, the isolated cleft looks directly into the subaortic outflow tract. Here is a very nice picture showing you a straddling and overriding mitral valve. As you see, the superior papillary muscle is within the morphologically right ventricle. And we see this most frequently in Tausig Bing malformation when there is double outlet from the right ventricle. Here is the situation where there is a tongue of tissue that is joining together the aortic mural leaflet, and that tongue of tissue is producing dual orifices within the valve. These orifices are rarely incompetent, and in this setting, in fact, it is wise not to try to divide that connecting tongue. So should the valve be incompetent, it's better to treat each of these orifices in its own right. So prolapse, perhaps the most important, and here I'd like to emphasize the significance of the caudal support. I've already shown you that in the normal heart, the leaflets have free edge cords throughout their length rather. And it's now quite some time that my old friend Anton Becker pointed out that one of the features of prolapsing mitral valve is the lack of support to those free edges. And here you see a beautiful example from Anton's archive. There you have isolated prolapse in the middle scallop of the valve. There is inadequate caudal support across its free edge, with this tendinous cord being elongated, another tendinous cord being ruptured. Moving on, malformations of the papillary muscles. And perhaps the most obvious here is the arcade or the hammock lesion. But then we also need to take note of the parachute malformation. So let me show you each of those in turn. Here is the nice example of the arcade or the hammock lesion. And the feature here is that there is a muscular arcade that joins together the tips of the two papillary muscles, along with incomplete formation of the intercordial spaces. And this makes the valve remarkably stenotic because there is very limited way that the blood can get from the left atrium into the left ventricle. And the same situation can occur when we have the so-called parachute malformation. That takes two particular types. In this one, removed in surgery, there is fusion of the normal, or rather the abnormal, superolateral and inferoseptal papillary muscles, and again thickening of the tendinous cords. But in the other variant, one of the papillary muscles is absent, so that the leaflets themselves are tethered by a solitary papillary muscle. Here, the inferoseptal papillary muscle with absence of the superolateral muscle. So there we go. I hope I've now shown you the mitral valvular complex, and I've shown you how all components of that valve can be congenitally malformed, either in isolation or as a combined lesion, pointing to the benefit of analyzing the valves according to the components of the complex, something that we're now going to follow for the other valves as we move to them in turn. So thank you for your attention regarding the mitral valve.
Thank you, Dr. Anderson, for taking us through all the morphological aspects of the mitral valve. It was indeed a master class. The forum is open for discussion. Each presentation is scheduled for 20 minutes, which includes 15 minutes of lecture and 5 minutes for discussion.
Yeah, good morning, Professor Anderson. At least it's a pleasure to see you over the screen. Few things I would like to say, that is, because this is a postgraduate training program and discussion, two of the things which not many people would have seen, all these valve, mitral valve, secondary to rheumatic infection, etc., is known to everybody. Lucky that the incidence is coming down. But there are two aspects I would like to emphasize, because many of the people here would not have seen it. One, still I remember, in 1975, I had a mitral incompetence in railway hospital. Like very few valves were done, and we had only this Star Edward valve. No other valve was in existence. So I still remember his name. His name was Mr. Dubey. He was from Bhopal. So he was posted for mitral valve replacement because nobody knew how to repair the valve. So when I opened, I found out that the valve looked normal. But he had severe mitral incompetence, mainly because the valve was plastered to the myocardium. When I picked up the valve and looked and found that the papillary muscles were completely absent. Again, totally plastered. And this is the first time I am seeing an EMF, endomyocardial fibrosis. So there was no other go other than replace the valve. So when we replaced the valve, we found that the cage will not sit there. So we devised an operation where we scooped out all this endocardial fibroelastosis muscle. That is how the term was coined, coring out of myocardium. So we did a coring out of myocardium and did a mitral valve replacement. And this patient, I followed him up for 18 years. Mind you, there was no anticoagulation at that time. That is number one. Number two, second pathology, which I don't know how many people would have seen. We had a girl, she was 1.5 years old, failure to thrive, huge heart, severe failure, and so, mind you, this is an era when there was no echocardiogram in this country at all. There was only one echocardiogram mode that was available in CMC Hospital, Vellore, with Dr. Vaidilingam, which was a present by Helen Taussig for her when she left Johns Hopkins. But that is not approachable for us. Anyway, we had somebody who had done his MD general medicine. He said this is mitral incompetence. So, what do you do? A child who is 1.5 years old and less than 7 kilos. Severe mitral incompetence, huge left atria, huge left ventricle. See, I was also very young. I was hardly 30. So you are stuck with this. So we decided that, like approaching mitral valve, we did a left thoracotomy. And when we did the left thoracotomy, we found out that she had an Alcapa. You know what was the treatment of Alcapa at that time? Ligation. So, what we did was, we thought we will do we have read about when we were young in the training program that Alcapa could be corrected by doing an anastomosis of the left subclavian artery to the pulmonary artery, which is removed from the left coronary artery removed from the pulmonary artery. Now, see, this is where we have to use our own innovative thinking. We dissected the left subclavian artery before heparinization. Now, how are you going to put the patient on bypass? If you want to replace a mitral valve, question of repair doesn't come. For 1.5 years, 7 kilos. Patient's name was Gayatri. So what do you do? How do you handle it? That not for your sake, I am talking this for the sake of, you said about 600 people, 400 people will be watching. For their sake, I am talking. They all know these things. So we dissected the left subclavian artery before heparinization and we cannulated the descending aorta. A single venous cannula into the right atrium. Went on bypass. There is no question of cardioplegia because nobody has heard of cardioplegia. You know when cardioplegia came into existence? The first reported case was Buckburn. That was when? Not many people won't know it. So there was no cardioplegia. There was no question of myocardial preservation at all. So we replaced the mitral valve through the left atrial appendage using a number 1 star M valve. And and anastomosis the subclavian artery to the left coronary artery using interrupted 7-row silk because there was no proline. And the patient did well. Afternoon, I'll show you the MRI done 3 years ago. You know how old is she now? She's 44 years old. She's on what? Just baby aspirin. Nothing else. No INR, nothing. So the mitral valve, in short, what I want to say is mitral valve anatomy pathology is very complex. This is one. The second thing is, Bob, I am very grateful to you for sending me that small write-up for my autobiography. It has been completed. Thank you for the help. Lastly, I would like to remind that we have lost one of the senior most cardiac surgeons in the country, Dr. William. Anyway, may his soul rest in peace. Thank you.
Thank you, Dr. Cherian, sir, for sharing your invaluable experience. The second presentation is by Dr. R. Krishna Kumar, a distinguished pediatric cardiologist, clinical professor and head at Amrita Hospital, Kochi. He is known for his advocacy for affordable cardiac care for children with congenital heart disease in low-resource settings. We have a recorded deliberation from him on rheumatic heart disease in children, the current scenario.
Just thank the Satya Institute along with Professor Cherian for this invitation. And I am to present the current scenario of rheumatic heart disease and rheumatic fever in children. I would present sort of a national perspective mostly, but there would be a global touch to it. So again, this talk is dedicated to Professor Tandon, who has inspired me not only to do pediatric cardiology, but also to pursue the interest and research in rheumatic heart disease. The historical perspective is important because the whole concept of juvenile mitral stenosis took birth from the work of Dr. Sujoy B. Roy. And this is an excerpt from his paper in Lancet, where he described what is notable really is the kind of numbers in terms of proportion of patients with rheumatic heart disease who were being admitted at that time. So of the 2,300 odd patients, 750 had rheumatic heart disease, and about a significant proportion of them, nearly a fifth of them, were under the age of 20 years, or to have, by definition, their definition, juvenile rheumatic heart disease. And predominantly, 9 and 8 had pure mitral stenosis. So this is their very important perspective. Now, if you look at the pathology of juvenile mitral stenosis, what I have here is on the top is 2D echo, which is illustrating, this is from an 8-year-old patient who had severe rheumatic mitral stenosis. This patient has severe fibrosis of the valve at the edges, with a very significant constriction of the mitral valve orifice, as you can see on the 2D echo above, and on the 3D echo below. The 3D echo is almost like a pathology specimen, and you can see the mitral valve orifice, which is like a fish mouth. Very importantly, when you look from within the ventricle at the bottom right, you see significant subvalvular fusion of the entire caudal apparatus with the leaflets. So the caudal apparatus and the leaflet have fused to become pillars, which contribute significantly to pathology. Now, this is unique of juvenile mitral stenosis, where you have tremendous subvalvular pathology, disproportionate pulmonary hypertension, and very severe disease. So that was the pattern that Dr. Sujoy Roy had described. And after that, of course, it's been a lot of work. The most recent review that I have actually co-authored in JAC outlines and summarizes the changes that have happened. Now the epidemiology has changed of rheumatic heart disease. Is largely determined by poverty. It has disappeared from relatively affluent parts of the world. It's so intimately linked to primary care, primary health care. The natural history is now looked at differently. Earlier, we used to think that it is all episodes of rheumatic fever that eventually translates into rheumatic heart disease. That's not the case anymore. Now we tend to see more patients who have rheumatic heart disease without noticeable rheumatic fever episodes. I mean, of course, you do have patients with rheumatic fever, but you also have this particular unique progression, which seems to be the dominant story. Now it's fairly accepted that skin infection can also cause rheumatic heart disease, and particularly in the populations that live in the Pacific Islands and in the Australasian populations. The Jones criteria has been revised and it's made context specific. The management now requires attention to the care continuum, and there is some flexibility with penicillin prophylaxis. Prevention is all about strengthening primary care. And of course, there is an important need to integrate rheumatic fever deeply into primary care and make it a part of universal health coverage. So this is the kind of paradigm, this is the kind of thinking structure that we have with rheumatic fever these days, rheumatic heart disease. And really, the models of disease progression that we thought, which was linear in the past, has changed to something like maybe there is a component of rheumatic fever, but there's also this rheumatic heart disease that develops from ongoing inflammation without any obvious episodes of rheumatic fever. So the contemporary model has evolved from the classical model, and currently you tend to have more patients with relatively subclinical heart disease, and generally many of them have a benign outcome. Of course, you do have progression, and that's what the current focus is on. So this is the kind of, when you look at it from a public health perspective, from a population perspective, you have a very large number of patients with subclinical rheumatic heart disease, and this is the dominant picture in children and in the young people nowadays, is that you have a large number of people with subclinical, a small proportion of which become obvious clinically, a smaller proportion have disability, and a tiny proportion have death. But in absolute numbers, these are quite formidable. The death, even now, from rheumatic heart disease, globally, is a very significant problem. However, it's a small proportion of the disease. We don't understand fully how this evolves, which subclinical disease goes on to clinical, etc. So what has changed in rheumatic heart disease? And I think we must go back to the efforts that were made in the first decade of this millennium, where we did perhaps the largest single global study on rheumatic heart disease. And we surveyed 10 districts in India. And each district had an approximate population of about 1 million or 10 lakhs. And we also did a school survey in each one of them. So there was a registry component and there was a school survey component. And we did very extensive partnerships with the state health department. All healthcare providers were identified. We did extensive networking. And we found something very interesting. So we had this situation where we had 10 districts in India, and we found that there was variability, of course, and some districts had a higher prevalence of rheumatic heart disease and some had low. Now, if you look at overall, the prevalence on school surveys, which is the active surveillance, the prevalence of rheumatic heart disease was 0.1 to 1 point. In our own Ernakulam Cochin district, we found when we screened 25,000 school children, we had just 3 patients with rheumatic heart. So that's very, very low indeed. Now, that's almost like Western data. So the median prevalence was sort of 1.4:1,000 in India. And the age distribution was very interesting. So wherever the prevalence was low, the disease tended to happen relatively later. So you take the example of Kochi, at the lowest prevalence, the green line that you see, had 2 peaks in the age of 50 to 54. And so these are the regions where the disease tends to manifest late. So, it's very interesting. So where the disease burden is the highest, that's when the disease tends to have the earliest manifestation. There was, of course, an availability bias. We were forced to investigate and look into regions that had a good health care structure with willing investigators. And the areas that had the poorest infrastructure, which is going to have the highest likelihood of disease, were not surveyed. If you look at the India's well-being district well-being index, most of our centers were located in the green areas and not on the red areas because we couldn't find anyone to do the study in the red area. So the secular trends over years in India shows that the disease is on a decline. Of course, with all the caveats that need to be there. And definitely it had come down considerably in India. However, it is still prevalent in pockets and we haven't investigated those pockets. What was really interesting is studies that were done serially in the same region. So this study was done by Dr. Negi from Shimla. Identical methods, 1991-2008. And there was a marked decline in rheumatic heart disease during this period. Very sharp decline. You can see overall RHD prevalence came down dramatically. Rural RHD came down, urban RHD came down dramatically. And what changed in that region was the marked improvement in literacy, per capita income, infant mortality rate, life expectancy. Everything changed. In fact, crowding did not change, but everything else changed. And that was associated with this remarkable decline. So, to sort of cut a long story short, advanced heart valve disease in children is almost exclusively associated with high endemicity. If you see juvenile MS, if you see severe mitral regurgitation in a child, in an 8-year-old, in a 10-year-old, as a result of rheumatic heart disease, the odds are very high that the child comes from a high endemic region. In low prevalence regions, in areas where the disease is rare, you hardly ever see rheumatic heart disease in children. That is manifest. You may see some subclinical heart disease, but not manifest heart disease. As the prevalence declines, the age gets pushed. Age at which you see most patients gets pushed. And as a result, juvenile MS has largely disappeared from most parts of the country. You do see, and the only juvenile MS I see are patients who come from African countries for balloon mitral valve water. But we don't see them in our part of the country very much. Of course, if you survey the high prevalence region, you'll find it. But if you were to survey across the country, you do have the method of surveying for subclinical RHD using the World Heart Federation criteria through echocardiography. Now here you can see that there is a very significant higher proportion of patients. This is a classic study that was published in NEJM long ago. And you can see that in all these countries where it was surveyed, we found that there was a very high prevalence of subclinical RHD as against clinical RHD. The natural history of subclinical RHD is not known. We don't understand this. We don't know whether we should give it penicillin. We also know that a lot of them, their disease may regress without penicillin. But progression is possible in younger patients or those with severe valvular involvement, as one would expect. In India, Dr. Anita Saxena conducted this very important study, which was published in the British Heart Journal, where it was found that there was a clear gradient on subclinical RHD. The prevalence was 26 per 1,000, which is rather high in rural government school, and 9 per 1,000 in the urban schools across the board. It was very interesting data that came out, and that was consistent with what was found with other populations. If you look at the high and low risk Australian population, and I was part of this analysis, we found that again there was a clear difference between the Caucasian population that lived in Australia and the Aboriginal population. So if you see, the Caucasian population is the line below. And the Aboriginal population is the dotted line and the black line, which is basically male and female. But you can see the incidence ratio, that is the number of cases that are of Aboriginal origin are 68, nearly 70 times that of the Caucasian origin. So there is a very clear difference between the populations. And much of that has to do with availability of healthcare. There is perhaps some genetic predisposition, but by and large, the disease is largely limited to populations in the world that have poor access to primary care. No matter where you go, you find this pattern. So who's most affected by RHD? The poor, the marginalized, the rural poor, to some extent the urban poor. And where are we as cardiologists practicing? We are practicing in urban populations. We deal with the urban middle class and the relatively affluent. So this population that is there at the bottom of the pyramid, that's 4 billion people, largely has slipped from our consciousness. That's a very distinct possibility. And that's therefore, we may be under the illusion that the disease is going away, when it is not going away from all populations. It's important to dwell on what has contributed most to the decline of rheumatic heart disease. It's important to recognize that the decline in rheumatic heart disease started even before penicillin was introduced. And this was very seminal studies that were demonstrating the annual incidence of rheumatic heart disease and the death, rheumatic fever and the death from rheumatic fever. And the decline clearly started before penicillin. You look at another disease, tuberculosis. Tuberculosis decline started well before you had BCG, chemotherapy, or pasteurization. You look at measles, you have the same story with measles. When the immunization began, the decline had already happened to a substantial extent. And immunization, of course, helped, but much of the decline was much before you did anything specific for the disease. On the other hand, if you look at the situation in the Soviet Union, when the breakup of Soviet Union happened, the incidence of rheumatic fever increased significantly in Central Asian countries where primary health care, which was guaranteed before the breakup, actually started to fall apart. So, by and large, rheumatic fever is linked intimately to primary care. So I decided to survey about 99 cardiovascular professionals in low and middle income countries in various specialties with a bias towards pediatric cardiology and with varying experience. And about 3/4 felt that the RHD had declined in their country. Then when you asked them whether they had any program for rheumatic heart disease, about a third had a program, but the rest had either no program or they didn't know about it. And in their view, what contributed most to the decline, again, approximately 70% felt it was access to basic health care. And targeted RHD control program was only a very tiny proportion. So the relationship, the causal pathway for translation of streptococcal infection to rheumatic heart disease is incredibly complex, and it's closely linked to a number of socioeconomic variables, socio-demographic variables, which is very hard to tease out. But clearly the association is very, very convincing. So here, it's very clear to me that rheumatic heart disease is much of a social disease. It's intimately related to kind of living conditions and access to healthcare. I should mention about this very important study that came in NEJM on the GOLD trial, where the subclinical rheumatic heart disease was tested through a randomized controlled trial. And it did show, of course, that your prophylaxis with penicillin prevented progression. But it's important to recognize that you had to treat a very large number of children who are subclinical heart disease who may not progress for prevention of progression in a small proportion. So we really could not translate this data into population-based challenges. The other important thing to recognize is that notwithstanding all the issues relating to prevention, we have to worry about the ones who have established heart disease. So managing children with established rheumatic heart disease is a very big challenge and continues to be a challenge, and nothing really has been done over the last 3 to 4 decades. We don't have any tailor-made solutions. We don't have any alternatives to what we had 30 years ago. We still have very poor access to care for most of our patients, heart valve repair really is continues to be impossible or challenging, or very, very difficult in patients with children with rheumatic heart disease. You may get an immediate result, but then again, the durability is very, very poor. And then, of course, the prosthetic valves are a big challenge in small children in terms of the size of the valves, the anticoagulation, and just the simple fact of giving penicillin injection to these children can be a huge challenge because of the pain it causes. So my parting thoughts are that like many other diseases, rheumatic heart disease will go away once primary care improves. Echo screening is intellectually screening, interesting to us cardiologists, but it really doesn't make sense. Like many things that we do as cardiologists do not make sense from a public health perspective. And the real fundamental challenges are socioeconomic, and really that's what comes in the way of care of the poorest. What we also need in rheumatic heart disease care is really interest, somebody who can take a passion, particularly the surgeons, and develop and nurture skills for heart valve repairs. It's desperately needed for these patients, and there is very little progress in this. Thank you.
Yeah, Dr. Krishna Kumar is there, sir, online to take our questions. Can you hear us, sir, Dr. Krishna Kumar?
Very well, I can hear you.
Yeah, I request the chairperson to take a lead. Put the mics on, please. Can you help?
Yeah, thank you, Kweke. That was a fantastic 360-degree viewpoint on the current status of rheumatic heart disease, and you covered more or less all aspects of that. We have time for one question. Kweke is on the line. Shiva, can you? Yeah, take your mic.
Thank you. Good morning, Dr. Krishna Kumar, Siva here. I thoroughly enjoyed your presentation as in a topic that you are so passionate about. You clearly defined the role of secondary prophylaxis in patients with the subclinical rheumatic heart disease. I just would, as from a surgeon's perspective, I just would like to take it a bit further, especially in those patients in whom you have performed successful valve repair surgeries. Now you are taking into consideration the durability of the valve repairs. In this instance, are there any kind of studies that have been done taking into consideration the secondary prophylaxis, which helps in maintaining the durability of a repaired competent valve? Thank you very much.
There haven't been enough studies on that area, but there are 2 studies from New Zealand that were published on the durability of valve repair as such. This was published by Bo Remeni, and what she found was that almost all heart valve repairs in rheumatic heart disease, particularly mitral valve, I don't think people attempt very much aortic valve repairs, but mitral valve repairs, by and large, do not last very long. They have varying degrees of failure. In the population she studies, she did not actually compare the patients who were not receiving prophylaxis. Most of them were actually receiving good prophylaxis. There was still a limited durability, 5 to 10 years on an average, after which varying degrees of regurgitation started. Even then, she concluded that it was still worth repairing because in those patients whom the valves were replaced, the compliance with anticoagulation and the failure rate and the incidence of stuck valves was significant enough, and deaths were quite high, that she felt, although the data is not compelling, that that patients should be valve repair should be offered as the first choice. In our own experience here, we've had several patients with rheumatic heart valve repair, but we've had instances where once they become teenagers, they just stop prophylaxing. It's very hard to convince some of these children, and they become very delinquent with it. And we've had very bad recurrences. The most recent one I saw yesterday. So it's extremely intuitive that you just have to give injectable penicillin as prophylaxis once you repair the valves. There is no escape from that because the process hasn't changed.
One last question from Vijay Kumar.
I said something related to the secondary prophylaxis. How long do you give secondary prophylaxis if somebody is doing well after the valve?
Prophylaxis has to be given for at least, so the traditional teaching is lifelong, but lifelong is unrealistic. So there is a very strong move, and I think it is going to be recommended very soon that you can, beyond the age of 40, you don't need to give secondary prophylaxis because the incidence of fresh recurrences of rheumatic fever is extremely unusual after the age of 40. So we've kind of, it's empirical, but we've kind of come to a reasonable consensus that up to 40 we can give secondary prophylaxis.
Thank you. Thank you.
Any more questions?
Yes. Good morning, Rekha. It was, as usual, wonderful presentation. Two things which you emphasize. One is the fish mouth mitral valve, mitral stenosis, especially occurring between the age of, say, 10 to 14. Now, the other is the mitral incompetence. To talk about mitral incompetence, we have Professor Kalangos here, because he has repaired a couple of valves for us in Parimala. Now, regarding the first one, I'll tell you one thing. We have operated some of these kids when there was no, when closed mitral valvotomy was the bread and butter of all the cardiac surgeons. But the problem was the kids who had this fish mouth mitral valve, you can make out only if you put your finger inside and feel the valve. And ultimately, you know, the TUPS dilator, which usually opens at to 2.5 centimeter, has been made smaller, and for kids, a special TUPS dilator was made, which will not open more than 1.25, because it will cause mitral incompetence. The subvalvular fusion is very severe. But all these patients needed prophylaxis. But we were giving at that time oral penicillin for a period of 1 year. Injections, one is expensive, and it was not a question of expense because we were working for the railways. Railway, it was not a big problem. But the parents won't bring the kids for injection. So oral penicillin was the treatment. One. The second thing is recurrence was very high. And when you see small valves, it is very difficult to repair, and it will be very difficult to replace also. See, that time there was the smallest valve available was 1 mm. That means it can have a surface area of around 1.25 square meter. Nothing more than that. So the choice of processes. Secondly, the prophylaxis. We have been practicing prophylaxis as per the WHO format. That is till the age of 45, I think. I have forgotten. I think it was till the age of 45. So I think most of the people follow it up, up to 40 or 45, as you said. Anyway, this pathology, one, it is disappearing. It is mainly now whatever we feel, C is congenital. So I'm glad that all over the world, prophylaxis has become very important. Secondly, small valves now, you have, somebody was telling me the other day, they put a 17 mm valve in an aortic root.
So 1 point. Can we have this discussion, the surgery of mitral valves, sir? In this, it's running short of time, sir.
Okay.
Yeah.
So anyway, your presentation for us, especially your experience with the rheumatic mitral stenosis, was very good. Thank you.
Thank you, Dr. Krishna Kumar, sir. As we fill in the gaps of the understanding of the rheumatic heart disease and there's a better implementation of the healthcare delivery systems, we may be able to control the disease. Now, next, after having the clear understanding of the morphology of the mitral valve and insights into the epidemiological burden of the rheumatic heart disease in Indian children, we next move on to the diagnosis and imaging of the mitral valve. So, may I now request Dr. Muralidhar Kanchi, who is the senior consultant and professor of anesthesia and critical care in NH Bangalore, to come on stage for his talk on role of pre-operative echocardiography to tailor surgical strategy and predict the outcome in congenital mitral valve disease. Over to you, sir.
Respected Chairman, my dear friends, ladies and gentlemen, thank you for this excellent opportunity to be in front of you this morning to deal with the role of echocardiography in the management of congenital mitral valve disease. I'm greatly indebted to the organizers of this meeting, especially Dr. Hiremat for this invitation. And in the next 15 to 20 minutes, I'll just quickly go through the role of echocardiography in congenital mitral valve disorders. Can I have the slide, please? Can I have the full screen? Oh, thank you. I got it. It's coming up. So, coming to the role of trans-esophageal echocardiography, what is the role of TE in patient congenital heart disease? This can be broadly divided into actually 4 groups, but I will concentrate on this one: immediate preoperative definition of cardiac anatomy and function, post-operative surgical result and function, how well the surgery has been done, especially in terms of evaluation of repair procedures, to monitor the ventricular function and volume status, and also to look at the intracardiac air at the end of bypass when you're coming off bypass. But we also need to know that what are the contraindications? These are some of the contraindications mentioned on the left side of the slide and the relative contraindications on the right side. And people have expertise and are familiar with echocardiography, use of transesophageal echocardiography in patients who have relative contraindication. It still can be done under with care by experts, especially when the benefits are greater than the risks. Coming to the probe selection, TE probe selection for infants and children basically rely upon 2 factors: what is the weight of the patient and the size of the probe. The equipment manufacturers dictate that in patients who are around 2.5 kilos, you use the micro probe, whereas in patients who are 3.5 to 30 kilos, we use the mini probe. And in patients who are more than 30 kilos, we could use the adult probe. And the relative sizes of these probes are mentioned here. The one which is labeled as A is the typical adult 2D echo probe. And C is the mini probe, and D is the micro probe. You can see that the diameter of this probe is much less as compared to this, and this could be used in children weighing 2.5, anywhere from 1.7 to 3 kilos, whereas this can be used for patients who are 3.5 to 30 kilos. And the one which is labeled as B is called the HTE probe, which is actually a monitoring tool in the intensive care unit for adults. It can be kept for 72 hours in the ICU for continuous monitoring of these patients, and it's just slightly bigger than the Rayleigh tube. And this is not used in children. It's just for comparison. It has been put up. When you use the TE, we have 4 windows: the upper esophageal window, The middle is esophageal window, the transgastric window, and the deep transgastric window, which are recommended to be used to delineate the morphology and function of the valves. And as described before, the mitral valve has 5 components: the annulus, the mitral valve leaflet as it is, and then the chordae, papillary muscle, and adjacent myocardium. All of these constitute what is called as mitral valve apparatus, and any problem with any one of them is likely to impair the function of the mitral valve. And Carpenter's description of the mitral valve is usually used internationally to describe the segments of the mitral valve, which can be described in the posterior mitral leaflet, antemitral leaflet. We have in the posterior mitral leaflet, we have 2 scallops which divide the posterior mitral into P1, P2, P3, and corresponding sections of the antemitral mitral leaflet. Though there are no scallops, are labeled as A1, A2, and A3. And this is the transesophageal orientation when we look at the mitral valve. At 0 degrees, we see the A2 and P2 segments. And at about 45 degrees, it cuts through the P3, A2, and P1 segments, as is delineated here. And in 2-chamber view, which is at 90 degrees, we cut through the P3, A3, A2, and A1. And at 120 to 140 degrees, well, that is shown as 135 degrees here, we cut through the P2 and A2 segments. And by knowing this, we will be able to identify the location of the lesion fairly precisely using the 2D echocardiography. And what are the structures which are in close relation to the mitral valve, which are shown in this diagram labeled panel A? In this, you can see that the aortic valve is the uppermost structure. We have the circumflex artery wrapping around the posterior annulus, and you have the bundle of his, and we have the intertrigonal distance here. What are the lesions which we are looking at when in children, especially in terms of congenital heart disease? We have the supramitral ring. It could be congenital valvular stenosis, double orifice mitral valve. All these were demonstrated in the morning by Robert Anderson. I'm thankful to him. The pathology was shown, so we'll see what it looks like in echocardiography. Before we do that, we'll just quickly go through the definitions. Mitral valve prolapse is defined as a condition where there is a systolic extension of one of the leaflets or one of the components of the leaflet beyond the annular plane, as is shown in the panel 2 and 3 in this picture. And a cleft mitral valve is present when the antemitral leaflet remains divided into 2 separate leaflet components, each of which attaches to a separate papillary muscle group. And isolated cleft mitral valve is the one where the cleft is associated in the absence of ostium primum defect. The same thing shown in 3D. And the congenital mitral stenosis is a condition where, as we all know, that there's impediment to the left ventricular filling as a result of narrowed mitral orifice. And the stridal mitral valve is defined as the presence of caudal attachment on both sides. This one of the attachments is on the other side of the ventricular septum, as is shown in the diagrammatic representation. And the double orifice mitral valve is defined as 2 separate orifices, each supported by its own chordae and papillary muscle, diagrammatically represented in a still image is shown. What are the views we look at when we see the mitral valve? Basically, we use anywhere from 6 to 8 views. The 4-chamber view is the most popular. As I already mentioned, we have the A2 and the P2 segments here. Then we have the 5-chamber. If you withdraw the probe about 1 centimeter from the 4-chamber, we would usually see the A1 and P1. And if you advance the probe slightly beyond the 4-chamber, we will also see the A3, P3. So at the same position, in the mid-esophageal position, slight adjustment of the probe in terms of advancement or withdrawal, we are able to see all the six components of the mitral valve: A1P1 in the upward level, A2P2 at the mid-esophageal level, and A3P3 at slightly lower level, where you could also see the coronary sinus draining into the right atrium. Then with the change in the angle, multiplane angle to about 40 degrees, we look at the commissural view, we use the P3, A2 and P1 segments. And with increase in the angle to about 90, we see the P3, A3, A2, A1 segments of the mitral valve. And increase the angle further to about 120 degrees, we see the P2 segment and the A2 segment in the long axis view. And when we go to the transgastric views, you get the basal short axis view, where we'll see the mitral valve as a fish mouth, which was demonstrated in the previous presentation in a 3D picture delineation. And in the long axis view, in the transgastric position, it is very important to look at the caudal apparatus, that is subvalvular apparatus. The 3D echocardiography, recently the 3D probe has been introduced in children, and this has been approved by the FDA, and we could get a clear-cut image. I'll quickly go through some of the echo pictures. I have mixed both transthoracic as well as transesophageal echo pictures. So this picture is a parasternal long axis view. Transthoracic echocardiography showing the prolapse of the antemitral leaflet clearly. The antemitral leaflet coming little above the annular plane. Then this is the transesophageal echocardiography showing prolapse of the anterior mitral leaflet. This 4-chamber view, this is the 2-chamber and the long axis view, etc., showing the eccentrically directed jet in the opposite direction to the prolapse. In prolapse, the jet is always directed to the opposite direction. Then this is a still image of the isolated mitral valve cleft. And in this transesophageal echocardiography, showing the mitral valve long axis view at 120 degrees, you can see that the cleft in the anterior mitral leaflet. On color echocardiography, you can see that there is a hole in the left, this antemitral leaflet, leading to regurgitation. Not only the regurgitation here, the cleft is also contributing to the regurgitation. This is a straddling mitral valve. You can see that the interventricular septum and the mitral valve is straddling. And the next picture I'm showing is the double orifice of the mitral valve, clearly seen here in a short axis view of the mitral valve. And this is the short axis view of the fetal echocardiography, where you're seeing the right ventricle, interventricular septum here, and the double orifice of the mitral valve clearly seen in a child yet to be born. This is one of the cases we had recently. This is the double outlet of mitral valve. Again, in 3D, you can see the two orifices in the mitral valve, one here and one here. Then coming to the mitral stenotic lesions, this is a patient who has mitral stenosis. You can see the flow acceleration occurring as the blood is passing from the left atrium to the left ventricle, and there is also submitral, bit of submitral, supramitral membrane. This is another case of mitral stenosis. The mitral valve is not opening. One more case. This is also mitral stenosis. And this is a case of parachute mitral valve. There's single papillary muscle. And the next one I'm going to show is that of a chord atrium. The differentiation between supramitral ring and the chord atrium is that the supramitral ring is below the level of the left atrium, whereas chord atrium, it is above the level of this membrane, is above the level of the left atrium, left atrial appendage, as is seen in this view. This is a case of supramitral ring, clearly seen here, and you can see the turbulence of the flow. This is a TE picture at the 120 degrees. And again, you can see the supramitral ring in a 4-chamber view, clearly seen. The surgical procedure is relatively simple. You peel off the membrane carefully without damaging the valve. Coming to the other congenital lesion is the Shaun complex. This is incomplete Shaun complex showing left ventricular hypertrophy and possible membrane in the aortic stenosis, sort of outflow tract obstruction. And then you have congenital mitral stenosis, bicuspid aortic valve, and this is the gradient across the aortic valve. The gradient was about 73 millimeters, which indicating severe obstruction to the left ventricular outflow tract. This is a case of accessory mitral valve tissue, which is obstructing the left ventricular outflow tract and aortic flow. And the gradient across the aortic valve, the LVOT is shown in the Doppler profile on the right bottom. A quick review of the cases in the last 2 years done in our hospital, in my center. There were 144 cases who underwent mitral valve procedures. The patients had congenital mitral lesions, and the age was between 1 day to 18 years. And these are the distribution of the cases. The mortality rate was about 4 in 144 cases. Coming to the end of my talk, what is the role of TE for mitral stenosis? The measures which are used is that if you would like to categorize the severity of the lesion either before or after the procedure, a Doppler gradient of less than 5 millimeters is considered mild or insignificant, potentially significant if the mean gradient is 5 to 8 millimeters, and certainly significant if it's more than 8 millimeters. For MR, objective parameters such as width of the vena contracta should be taken into consideration. And if the vena contracta is 4 millimeter, it is less than 4. It is 2 to 4 millimeters. It is moderate. More than 4 millimeters, it is considered to be significant. And also other parameters can be done, but the problem with the congenital heart disease is that, especially in children, the parameters are not as well defined as in the adults, especially in terms of numerical figures. And I would like to announce or highlight that next month we are having a sort of international TE workshop. Please join us. And I'm also happy to say that this certificate course and this fellowship course in critical care echocardiography, which is largely supported by the Indian Association of Cardiothoracic Surgeons, is doing very well with a lot of interest. We do conduct regular seminars on Sunday between 9 to 10 a.m. in the morning on the online, and it is well attended. And I request you to join us for the same. And thank you so much for your patient hearing. And if there are comments or questions, I'll be happy to take them.
Thank you, Dr. Muralidhar. I'm Dr. Baiju from Srijitra. Nice to see you. Excellent presentation. Very good images as well. I enjoyed thoroughly. I have a couple of questions. One is, what is your experience with the mini TE probe? Like, I often find the spatial resolution is so less, and it often overestimates the regurgitation when you compare to epicardial echo. Do you share the same experience, or you're very happy with it?
Thank you for that question. Very, very well done. The couple of things we need to keep in mind when you use the TE probe is that there are problems associated with it. The compression of the airway or the accidental extubation can occur, and also some incidents of supraventricular or cardiac arrhythmias have been described. Coming to your point, mini probe, the resolution as compared to that probe will be slightly less because number of crystals contained in mini and micro probes is much less, or sometimes half the number of crystals contained in the as compared to the adult probe. So the quality of image, though excellent, it is not exactly comparable to what you see in adult probes. And adult probes, if it is possible, if you are able to use the adult probe in a child, especially if they are more than 25 kilos, that is better than the mini probe. But actually, if you use the bigger probe in a smaller child, the risk of esophageal rupture is real and that is going to contribute to the mortality then and there. So this has to be kept in mind. I don't know whether I answered your question.
Yeah.
I think it gives
So
reasonable.
what would you prefer? You prefer micro T probe or an epicardial echo?
Micro T probe, go for, I'll go for micro.
Okay. Next question, like we have a lot of young surgeons.
Yes.
What are your echocardiographic targets when you take a child for mitral valve repair? When you really don't have an option of replacement, like you say, this is okay, this will accept, or you'll ask your surgeon, this is not acceptable, we need to do something different.
Yes.
What are your I know it's contextual, but still, what are your thoughts on that?
So what is described in literature and what we follow is in terms of obstruction, it is the gradients. We go by gradients. Any gradient less than 5 millimeters mean gradient is considered to be not significant. 5 to 8 is you have to weigh the advantages. But if it is certainly more than 8 millimeters, we have to address it then and there. Similarly, for regurgitation, we look at the jet area. Having optimized the hemodynamics, it is important to optimize the hemodynamics because the jet area is influenced by several factors, technical factors, as well as the factors which relate to the hemodynamics. So the vena contracta, in adults, it is 3, 7, and more than 7, but in pediatrics, it's 2, 4, and more than 4 millimeters width in a reasonable sized infant or child. These are the factors which you consider.
Is there a vena contractor index to the body surface area for mitral valve? I see there is one for aortic valve, but I have not seen one for the mitral valve.
These we have to always contextualize these measures to the body surface area, and it is a good idea to relate it to the body surface area. I'm not aware of any equation for this. Aortic valve. Yes.
That was an excellent talk. Thank you so much for that. I think one of the things to answer that question, because it's actually in a talk I'm going to be giving, but the Boston group actually looked at that. What are the parameters after you do a repair for a chance of coming back? And what they used was gradient more than 5 millimeters and anything of regurgitation of mild plus. I think 50% of those patients came back. And then if it was more than mild to moderate, I think three quarters of those patients came back. So they use those as their parameters.
Sure. Thank you for your.
Just to encourage online viewers, can you push that question? Yeah. Dr. Muralidhar, can you just answer the
Prosthetic mitral valve malfunction in congenital MS. What the echocardiographer must search for etiology. Prosthetic mitral valve malfunction.
I think he's talking about blocked, choked mitral valve.
So it depends whether it is acutely happened or it has happened over a period of time. If it has acutely happened on the table, we have to look at the valve leaflet motion, whether there is any tissue impeding the closure of the valve or opening of the valve. And is there any suture or any material which is coming in between? What's the relationship of the valve to the papillary muscles, etc.? All those things have to be done within the operating room. But if it is occurring later, whether it is a thrombosed valve or there is a pannus formation, we have to look into those details and then look at the gradients and then decide to whether you want to thrombolize or subject the patient for surgery. Thank you.
Yeah, Lakshman Das was from South Africa.
Yes.
And I encourage all people to type in their questions in the chat box during the presentation. Over to the chair, please.
Thank you.
Yeah, maybe we can take one last question.
I'm Dr. Maruti from UN Mehta Hospital.
Right.
So how you go about eccentric jet in pediatric repairs?
Very nice question. Eccentric jets are in principle to be treated as severe jets. So whatever is applicable to severe MR should be applicable to eccentric jets. Yeah, absolutely. Because of the coin effect, the jet may look narrow, but as it is opposing the LA wall, it becomes smaller and smaller, but actually it is severe.
Congenital mitral stenosis, particularly hammock valve and parachute valve, which are very difficult substrate, particularly in young children and all. Is your parameters of assessment post-op are the same as repairing rheumatic valves?
I think it is
because we need to accept probably a little more gradient in those kind of cases. Because if you are trying to open hammock valve or parachute valve more, you may land up in more regurgitation. So, do you have any thoughts on those cases?
No, I agree with you. Because mitral valve replacement not a easy choice in these patients. As long as you're happy with the opening of the valve and the hemodynamics, you might have to accept what is optimal for that case at that particular situation. Thank you.
Thank you.
Thank you, Murli.
Thank you.
That was very nice talk.
Thank you.
We move on to the next presentation by Professor Kalangos. What are the challenging conditions in mitral valve surgery in children? How to deal with it?
Change. To change. Yes, the pointer.
No pointers.
No pointer. No. Huh? Good morning again, dear Chairman. I will try to go through the challenging conditions in mitral valve surgery in children, how to deal with. Now, there is, for me, three challenging conditions. The first one, which is a very complex condition, is the mitral valve surgery at a younger age with a small mitral annulus. The second one is the alternative solutions to conventional ring annuloplasty due to the lack of pediatric sizes, especially in this conventional traditional rings. And the third one is the use of artificial cords in children. Use or not to use. Now, as I mentioned before, the mitral valve surgery at a younger age with a small mitral annulus is really one of the most complex challenges for a cardiac surgeon. And if really the surgeon would like to properly deal with this problem, he should be able to apply a mitral valve repair aggressively. Try to do everything to repair this valve. And for that, he has to get enough experience on mitral valve repair. He has to be able to use some modifications or improvement of standard repair techniques in order to achieve an acceptable result, which is the avoidance of any residual post-repair mitral dysfunction. Now, everybody knows the specific benefits of mitral valve repair in children, which are similar than adults. First, is the preservation of the left ventricular function. There is no need for anticoagulation. And in terms of durability is very good in valve performance, especially in pure mitral insufficiency. And the second specific benefit is the fact that mitral valve repair allows annular growth. On the other hand, the second option is to replace the mitral valve, and everybody again knows the specific drawbacks of mitral valve prosthesis in children. Unfortunately, children, they have very accelerated calcium metabolism, and there is, a very fast structural deterioration in case of mitral valve replacement with bioprosthesis. And especially with the mechanical prosthesis, there is the risk of thrombosis and thromboembolic complications. The risk of death is proportional to prosthesis annulus ratio, and the need for re-replacement is inversely proportional to the size of prosthesis. Now, what to do if repair is not feasible? Everybody knows that the smallest approved size of mechanical prosthesis is 15 millimeters. If really the annulus is smaller, the first thing to do is to try to implant this mechanical prosthesis in supraannular position. And this one sometimes also is very complicated, especially in cases where the left atrial space is small. In those cases, now there is a new option. I would like to present this one, and it was published, it was a multicentric study in which 17 centers participated and published in Circulation Cardiovascular Intervention in 2018, is to replace the atrioventricular valves with a melody valve. And in this multicentric study, there was 59 patients in mitral position. The median age was 8 months, and the median size at implantation was 14 millimeters. Regarding the technique, as you see here, I don't have the pointer, I don't know how to do it. Yes, here. In the middle segment of the melody valve, first you have to implant a pericardial stitch, either with an interrupted suture or with a running suture. And then usually what you have to do is to trim the distal or the proximal part, because if the distal part entering into the left ventricular cavity is too long, it will create left ventricular outflow tract obstruction. And sometimes is also better, to cut a V-shaped, to create a V-shaped opening towards the left ventricular outflow tract in order to avoid any obstruction at this level. And then you implant this melody valve by using this pericardial strip to implant it on the native mitral annulus. Again, you can use either interrupted stitches or running suture, and then you put the balloon and you dilate. Usually, regarding the dilatation level, you have to measure the anteroposterior diameter of the mitral orifice. For example, if it's 13, you have to go 1 millimeter up to 14 during the dilatation, not more, because otherwise, you will interfere with the good coaptation surface of the 3 leaflets of the melody valve. Now, regarding the results they published, as you see at the second year, there was 28% risk of death, 20% risk of structural valve deterioration or re-replacement, and the combination of these 3 events, mortality, structural valve deterioration, and the valve replacement was 45% at the second postoperative year. Finally, the freedom from mortality was 76% at 12 months, and as you see, 72% and 24 months. In 37% of cases, there was a need for balloon dilatation of the valve after a median time interval of 6.9 months due to increasing gradients. As you see, the balloon dilatation in these cases was very successful by decreasing the preoperative transmitral gradient to acceptable levels, and there was no significant increase in post-dilatation mitral insufficiency. Here, there is a case in which surgeons were obliged to explant the valve, as you see, because there was a prolapse of one of the melody valve's leaflet with a significant mitral insufficiency. And as you see here, where there is a black arrow, there was a perforation because these leaflets are very thin and they are very fragile. And globally, the results are not so good for a clinical condition which is really very disparate. 55% of these patients, unfortunately, would be expected to be free from death or orthotopic heart transplant, structural valve deterioration, or valve replacement at 12 months. I hope you know the results with the new generation of valves and technologies will improve in this field. Now, the second challenging condition is the alternative solution to conventional ring annuloplasty due to the lack of pediatric sizes. And here, what is the rationale of annuloplasty in children? This one also was the subject of a big debate over the past many years. And now everybody agrees that annuloplasty is helpful, is useful in children when you repair the mitral valve, because you have to maintain the relationship valve tissue area, surface of mitral orifice, especially in systole, but the annuloplasty must allow for growth. It's mandatory for all cases of mitral regurgitation, and it should be also used in some cases of mitral stenosis, especially when you do commissurotomy. It could be, some leaks from these commissural areas. And if you would like to improve after your commissurotomy, the coaptation surface between the anterior and posterior leaflets, you have to implant a annuloplasty ring. Now, regarding the remodeling annuloplasty with traditional rings, if really you are borderline and if you would like to implant a conventional ring, what you can do, you can enlarge the posterior, usually the posterior leaflet, and sometimes the anterior leaflet in order to be able to implant a size bigger than 26 or bigger. This one is the other option if you are, below 26 or 24, because there is now the physio ring, which has also a size 24. There is also several techniques of annuloplasty, and the most frequent one is to use a pericardial or Gore-Tex strip, as we did on the yesterday's case, which was a VST with a congenital short-chordate tendinous syndrome of mitral valve, and there was also a congenital tricuspid valve insufficiency with an isolated anterior leaflet cleft. And we fixed all these problems. And regarding the mitral valve repair, I prefer to use the pericardial, the autologous pericardial strip. And there was also a variation of this technique described by Paneth and Gerbaudet. First, they do the plication with a running suture at the annular level, and then they reinforce this running suture, this plication done by the running suture, by implanting on that a pericardial strip. Then you can, the other option, if you have the impression that some of the posterior annular segments are more dilated and deformed than the others, you can use this interrupted strip annuloplasty. Or you can do also the plication by using a Gore-Tex suture from one fibrous trigon from the anterior to the posterior, and then again from posterior trigon to the anterior, and tie the two halves of this Gore-Tex suture material on itself at the midline portion of the posterior native annulus. The other one is K-volar commissuroplasty, which consists of plicating the both commissure areas with pledged reinforced sutures. I don't appreciate because usually I had, to intervene in some cases with this kind of annuloplasty. And I noticed that there was, huge calcifications at this commercial plicated areas. There was, a very strong fibrous reaction. And I believe this technique decreases the possibility, the probability to re-repair the valve. And especially the commercial areas, both commercial areas are very important in the function of the mitral valve. And for autism, don't sacrifice, please, this very useful areas of the mitral valve. And then there is a biodegradable ring, which is 1,6 polydiaxanone with a specific molecular weight. There is the mitral and the tricuspid version. As you see, we conducted a experimental study 20 years ago. We implanted the smallest ring size, tricuspid ring size in small pigs. And here you see just in pigs sacrificed after 1 month of implantation. The rings, the biodegradable rings is implanted into the native portion between the posteroceptal commissure and the anteroceptal commissure. And then at 3 months, the degradation progressively starts. At 9 months, there is a very strong, the ring is completely disappeared. As you see, at 6 months, the biodegradable material is completely absorbed. At 9 months, there is a strong fibrous reaction formed in the space left by the degraded ring. And 6 months after the complete degradation of the ring, there is still a strong fibrous reaction persisting in this space left by the degraded ring. Now, the third challenging condition is the use of artificial cords. Now, there is some reports about calcified and ruptured artificial cords causing recurrent mitral regurgitation after 6 to 14 years after mitral valve repair in adults. But I will show you the 2 clinical studies done in children with long-term results. They are more encouraging us to use this ring. And by telling that the limitation of the Gore-Tex suture does not have the potential of growth with somatic growth in children has not been solved. But as you will see in this, here is the technique. But before the technique, I have also to reply to this question because they notice, all these surgeons who are familiar with the use of this artificial cords, that there is a compensatory extensive growth of the mitral leaflet and papillary muscle. And this one is the main mechanism for biological adaptation in terms of length. And it means you correct the prolapse, and then this prolapse will not be converted into a restrictive motion over the coming many years. As you so here the survival rate in the study published very good is 100% at 1 year, 100% at 5 years, 89% at 10 years, and the freedom, this one is more important than the survival, and the freedom from reoperation is 73 at 1 year, 65 at 5 years, and 65 again at 10 years. Go back now regarding the technique. This one is important. How to measure the appropriate length. You put your stitch with a Gore-Tex suture on the prolapsing segment of the anterior and sometimes of the posterior leaflet, and then you go to the anterior or sometimes to the posterior papillary muscle. You pull up the two halves of the stitch, and then with a hook you have to choose a posterior leaflet cord which has a physiological length, and based on this length you have to adjust the distance of the knot. Usually, I notice that it's not easy to do this one because usually, it's sliding and you cannot do very precise. And for that reason, I modified this technique. Now I'm taking, a small tube of tourniquet, a small segment. First, I measure the length of a normal posterior cord, and then I split this tube into two halves. I introduce the two halves of the Gore-Tex suture, and then I tie on the tourniquet, and then I remove because it's split, and really is very easy. And this one is really very precise. I recommend it to be used by everyone. You will be happy. Then there is a second paper, as I have mentioned, a 17-year experience with artificial cords. And as you see, the freedom from reoperation, as in the first paper, is very good, 90% at 16 years. Now, in conclusion, I can tell the feasibility of mitral valve repair, especially in very young children, is the unique option. Nobody, can contest this one. A repair can be palliative or semi-palliative operations during infancy and childhood with stenotic or mixed lesions. And in these conditions, I believe the main target should be the fact to buy time and consider the I will say imperfect mitral valve repair is a bridge to a late replacement. And then sometimes, you have to accept some residual stenosis and regurgitation. This one is the compromise part. There was, the lecture before me, there was the compromise regarding the mean gradients over than 8 millimeter of mercury, especially with HAMO or with arcade valve, with mixed lesions, try to accept even, gradients above 8 millimeter of mercury, because the other option is not the best option. This one should be very clear message, the take-home message. Repair is durable in the majority of cases with pure mitral insufficiency. And I strongly believe also that after, seeing this paper and after, using the artificial cords, the use of artificial cord can increase the feasibility rate of repair. Avoid procedures preventing the growth of the annulus. And for this reason, I strongly believe again that biodegradable rings will be in the near future a very attractive option, especially in the pediatric population. And the last take-home message is to avoid additional procedures leading to technically complex operation to treat residual lesions with prohibitive high risk, because the replacement option is precarious. Thank you very much.
Professor Kalangos, thank you so much for the presentation. It's great to see you again. For all of you who don't know, Professor Kalangos was my mentor during my fellowship days. Prof, my question to you is, during our days there, you had implanted a lot of biodegradable rings. And I had assisted you in several cases. And I think one of the most challenging issues that we faced at that time was the mixed lesions of mitral regurgitation with mitral stenosis. So how did they go after that? Because I remember the first couple of years they did quite well, the African children that we had operated in Switzerland. But then how was the long-term follow after that for these kids?
Yeah. Now you know this mixed lesions you have in two different etiologies in children. The first one is the congenital the etiology. Unfortunately, you know, in these cases, the midterm results are not good. I will present, you know, during my second lecture, you will see in my personal series, especially in the mixed and stenotic lesions at 10 years, the freedom from reoperation is 47%. This one is the honest version. Yes, we are failing, and we know that in half of these cases, in midterm, we will fail. The second etiology responsible of this kind of mixed lesion is the rheumatic involvement. And in the rheumatic involvement, in my series, especially the risk factor is, you know, after the operation, if you are obliged, you know, to leave the operating theater with mean transmitral gradients above 8 millimeter of mercury, this one also is the risk factor. And this fact, if you use a congenital annuloplasty, you know, as you know, we compared the impact in the rheumatic mitral valve disease, the positive impact of the biodegradable ring over the conventional rings. And we notice in these mixed lesions, it's better to use a biodegradable ring, because with the biodegradable ring, contrary to the conventional rings, you preserve the motion of the impaired motion of the posterior leaflet. With the use of conventional rings, you completely condemn the motion of the posterior leaflet, which will affect the opening surface of the mitral valve, especially during diastole. And this paper was published in the Annals of Thoracic Surgery. And I believe, again, even, you know, for bigger sizes, there is also a lot of positive effects in using the biodegradable rings in the mixed lesions.
I've got a question for you. It sounds a very basic question. Mitral stenosis is more challenging than mitral regurgitation. And what would be a choice of exposure in a small baby? Say for 3 months, 4 months.
Yeah, you know, this one, good question. Usually, you know, I use a very extensive, because they have usually, you know, small left ventricular cavity, for left atrial cavity. And for that reason, you know, I use the Girodon incision. I cannulate the superior vena cava, and I'm prolonging my incision towards the roof of the left atrium, in order, you know, to get a very good exposure. Because during the first year of life, the mitral tissue, as well as the tricuspid tissue and all the valves tissue, the native tissue, is immature. And for that reason, you know, you have to be very careful. Even, you know, when you touch with your forceps, you can damage easily, because the content of water is very high during the first year of life in the valvular tissue. And for that reason, you have to be, and for that reason, the exposure is very important. And I do the Girodon incision. You open like a book, the heart, and you can do everything. Sometimes, when I have, you know, the stenotic lesions, perhaps, you know, is also better if you would like to work on the subvalvular apparatus. Is better, you know, to detach the anterior leaflet from the native annulus and go into the left ventricular cavity and do properly things. This one is also important. Don't be afraid, you know, to detach the posterior, especially what I do, you know, for the hammock valve. I do, you know, a posterior detachment of the posterior leaflet, and I create a posterior papillary muscle by detaching the abnormal papillary muscle from the posterior left ventricular wall. and giving, more mobility. But you have to be very careful because you can perforate the left posterior, left ventricular wall. It's a challenging condition. Yes.
Thank you. Thank you so much.
Thank you.
Yes, one question. Yeah.
Professor Kalangos, can I have a comment about the annuloplasty you've told?
Yeah.
Most of the children with the regurgitation lesion will need some form of annuloplasty. But whether to put an artificial material like in pericardium or not, how do we decide? Like, is it according? I'm asking this because of some bad experience of parenthetical annuloplasty we used to do with a pericardial strip. Of around 30 we did. 4 of them came back with significant gradient. Luckily for us, it comes off and it can peel off like a fibrosis. But 4 of them needed reoperation for stenosis alone.
Yeah.
So from that point of time, we have sort of moved off from putting a pericardium, especially in smaller kids.
Yes, it's true.
So
yes, for mitral insufficiency, there is no doubt. You have to do annuloplasty. But for mitral stenosis, I do my commissurotomy or the other additional techniques, and then do the testing. If there is leak, sometimes, because in mitral, the mitral annulus is also small in these children, and I don't want to put even, a biodegradable ring. I do, at the commercial area, not the Wooler technique, but I put, a small pericardial patch at both commercial areas. And this one can be useful. You don't like it a lot.
And for the younger surgeons, another thing I learned is that when you're putting pericardium, you should make the edge rounded off.
Yeah.
If you put it sharp, it'll produce fibrosis.
Yeah.
That's one mistake I was doing before, and younger people should not repeat.
Very good.
Just a comment to emphasize on the use of artificial cord in mitral valve repair. When I was working with Mr. Siva, we published his experience of 146 patients mitral valve repair using artificial cords with 15 years freedom from reoperation with a good outcome.
I am not against the use. For example, yesterday, there was a case, Dr. Hirman. Yes. What I told you, I had the option to use an artificial cord. But then I did a posterior primary cord implantation translocation to the anterior A2. Because I told him, I'm sure that this child will not again come to surgery again, because it will grow up according to the general growth of the child. This one is sure. Because unfortunately, in my past experience, especially in children below 5 years, I had, some restricted motion after the first one, after 2 years. And when, I reoperated reoperated on this child, I had the impression that, there was a very strong fibrous reaction. And especially it was, a rheumatic etiology. Perhaps, in rheumatic etiology, as there is a hyperproduction of fibrous reaction, we have to be very careful because each rheumatic fever attack can generate, an extensive fibrosis, a hyperfibrosis, and for it is. But then the second case I reoperated on was, after 4 years. It was, a congenital mitral insufficiency with elongated primary chordae of the anterior commissure. I put, 2 artificial cords, and really there was no growth. There was a very nice fibrous reaction. I started wondering, asking myself what I made wrong. Yes, it was properly, it was completely, I had the impression that there was no artificial ring. It was, completely incorporated this material into the structure, the anatomic structure of the mitral valve. But again, it was short. And now why? It means in some cases, this mechanism, this compensatory mechanism, which consists of having, this growth of the neighboring tissues that doesn't work. It means.
In fact, yesterday we had the opportunity to operate 2 cases with Dr. Kalangos, and he showed us the technique he's so particular that no artificial tissue to be used in pediatrics. That is his concept. He tries to see that the natural tissues are utilized, whether it's a caudal transfer. If you have P3 prolapse, he excises the P3 segment totally and creates a new P3. This is what we happen to see, and his bites, technical bites, to fix up the annulus are very technical, wherein we all need to learn what we learned or what we see in our conferences. Some new things we happen to learn. If possible, I will try to edit those videos and show him. He has his own collections. That's one. And I request Dr. Carlos Mistas is online. He would like to ask some questions to Kalangos. Dr. Carlos, you are there, please?
Yeah, hello.
Please, welcome, sir. Welcome. Please go ahead.
Yeah, good morning, Dr. Hiramat and esteemed colleagues. Just one comment on what Dr. Kalangos said about the biodegradable ring. Actually, I had the pleasure to join him for the experimental studies in the PIC model 20 years ago. And I think that although we know that there are different types of population in the adult and pediatric population, the advantages and disadvantages have been described now. I think there are basically two things with regards to biodegradable ring. One is, of course, its own nature. I think Dr. Sanjay Cherian just made a point about the real long-term follow-up. But of course, these are data to be collected. And the second one is probably an increased resistance to infection, which was confirmed in an experimental work also in the rat model a few years ago. I don't remember exactly, correct me, Dr. Kalangos, if I'm wrong, 7, 8, or 9 years ago, in the rat model, in which you compare the resistance of infection when you implanted infected and uninfected ring. So probably these two major aspects of the biodegradable ring could be a part of the thinking in the equation of when, on how, on what to do when you have to repair the mitral valve in a child. I mean, of course, I'm not talking about the neonate, which is a different population, but for the regular children, probably these two characteristics are, in my humble opinion, something that might be taken into account at the time of taking a decision for this type of repair in patients in whom annuloplasty is definitely required. So thank you very much.
Thank you, Carlos.
Thank you, sir. I think we'll move on to the next session, please. Dr. Annie.
I invite on stage our next speaker, Dr. Sunil Kaushal, the Director and Chief Pediatric Cardiac Surgeon at Fortis Hospital, Jaipur. Through his presentation, he will be sharing his experience on repair of Myxomatous mitral valve in children with Marfan syndrome.
One of the things that I have seen is that below 1 year, it's far better to use native tissue. Whereas above a year, if you use artificial cords, the papillary muscles tends to elongate. But in below 1 year, I prefer to transpose the posterior chordae, and it seems to be working well with that subset. I mean, Carpenter used it even for much dissing. But my personal problem with rheumatic, where I prefer to have artificial cords, is that chordae doesn't get retracted like the native cords. And you need to, that's one thing that I've seen.
Respected Chairperson, dear colleagues, I'm thankful to team SMSIMS and especially Dr. Hiramat for the opportunity. I'll be presenting our experience with mitral valve repair in Marfan babies. What are the challenges we faced? As we all know, the Marfan syndrome is a inherited autosomal dominant connective tissue disorder and mutation of fibrillin gene. In turn, Marfan was this original article described only about the skeletal and the ocular manifestations of the Marfan. The credit goes to the McKissick and Taussig for the elaborating more on the serious cardiovascular features of the Marfan syndrome. And the current diagnostic criteria was set in Belgium in 1996. In early 1960 or 70s, the surgeons were frustrated because of the attempted repairs were coming back with a very high incidence of regurgitations. So in 1970s, 1980s, the few advanced techniques were especially invented by Dr. Carpenter, especially the most popular one, the resection and the bilateral sliding plasty of PML, which led to better results of mitral valve repair in babies. Pathological changes of mitral valve, it's Myxomatous changes of the leaflets, it's a sine qua non or the basic change which will lead to enlarged and petulous leaflets, especially the unileaflet or bileaflet prolapse of the mitral valve. And it will also lead to elongated and ruptured chordae. The annular dilation, which is usually not more in the younger child. The mitral association, the Marfan is very high. About 80% of the Marfans have Marfan mitral valve dysfunction. The younger the child, the most likely it will be very significantly mitral valve dysfunction, and the baby will be female. And out of those 80%, 10 to 20% will require mitral valve intervention at early age. Indications are like a significant MR, the failure, resistant failure, progressive ventricular chamber dilatations, arrhythmias, hypertension, and the lesser is for the patients. If baby also require concomitant surgery, it's quite rare in a younger child. Our surgical philosophy, as Dr. Kalangos also described, it's a conservative approach. Respect the leaflet or not resect the leaflet. Like that's why probably the bilateral sliding plasty in the is being used less and less, and give space for the annular growth potential. So that is our philosophy as well. So I knew about Dr. Kalangos' passion for the annuloplasty, so I removed most of the annuloplasty rings and replaced with my surgical picks. And focus is more on the commissuroplasty and the partial annuloplasty, and try to address the several apparatus that is the chordae as much as possible. The various surgical techniques we use, probably all of us used, are leaflet optimal sizing, that is reduction and resection if it's badly needed, and the patch plastic. The PML leaflets needs more attention than the AML, and the AML's chordae needs more attention than the PML's chordae. And the other techniques are free margin suspension of the plication, if its margin is quite redundant. So endoplasty, we prefer the partial or interpreted or half circle endoplasty, or commissuroplasty, like Dr. Kalangos also described, the new chordae insertion and the chordal elongation shortening, especially at the PM level and the cuspal level. Presenting our experience of the 11 cases, presentation will be focused more on the different techniques we clubbed together into different headings rather than going case to case. So this is a case of a younger girl with a bileaflet prolapse and significant MR at multiple jets. You can see. To big LA, multiple jets MR, bilateral prolapse. There's another patient with significant MR. Only the AML is prolapsing more, while PML is restricted up to annular level only. You can see here, PML is at the annular level only, while AML is prolapsing too much, bulging into the LA. It's a pre-operative. You can see the LV ventricle is almost attempting to come out of the pericardial cavity. LV is tense and full distended. Approach is usually through the mitral valve is inspected case to case. As you can see here, the both AML and the PML are too big legs, while chordaes are not that elongated in this particular case. competency is being checked. As you can see, this case we'll discuss later as well. You can see there is a gap in the posteromedial commissure area, while AML is prolapsing in the A1 and the P1 areas. It's another case with only mostly the chordaes of the AML are prolapsing. The multiple chordaes are elongated, leading to the AML prolapse. The same case, AML prolapse because of the elongated chordaes. AML itself is not that big. It's another case, so that girl with a hugely dilated, enlarged legs, papillary muscles, bileaflet prolapse, elongated chordaes, the classical case. So you can see the AML and PML both are bulging into the LA, leading to severe MR. So the subvalvular apparatus is being examined. You can see the elongated chordae. AML is coming up to the posterior mitral valve margin. The thick elongated chordae of the AML. There's another case with multiple elongated chordaes with not that enlarged leaflets. The various surgical techniques which we usually prefer, like first is caudal shortening. This is done by two levels, the papillary muscle and cuspal levels. As you can see on the left side, the caudal shortening is being done at perimembranous, at the papillary muscle level. The sutures are being tied. We used to take that technique of, as Dr. Kalangos described, but it was found to be time consuming. So we adopted this approach of eyelid detectors is being retracted by assistant. And the level of retraction is determined by the pre-time knot length of the loop sutures which we used for caudal shortening. The multiple chordaes are being shortened at papillary muscle level. It's another video showing how we use eyelid detector to determine the probable length of the chordae. He won't move the eyelid detector while I'm tying off the knot. Now the chordae is being shortened at cuspal level. So the length is being determined and assessed. In this thing, we can see the chordae is being shortened at cuspal level. On right side, you can see the post tying of sutures. Excessive leaflets are resected, and reduction plasty is the next technique we mostly used in very redundant leaflet scenario. You can see that that girl, the PML is being a particular oblong segment of the PML is being excised. Width is determined by the length of the cooptation line between AML and PML, probable or potential cooptation area. While moving forward, we have to be very careful about the primary or secondary cordia attached to this leaflet. One should not be that aggressive. As you can see, the caudal attachment in the body of the leaflet. Unnecessary cords are excised. We leave a tissue behind for the primary closure of this gap. You should not be that aggressive. Since the gap is being closed, you should lock your sutures in between, otherwise it will have a bursting effect and it will distort the body of the leaflet. In this particular case, as I described earlier, the caudal plication at A1 or P1, A2, AML led to the anterior advancement of the cooptation line, and that led to shortening of the PML. So PML was not falling into the cooptation line in that particular zone. So I have to advance the post PML. As you can see a horizontal incision is being made. The incision is extended towards the P1. This gap is filled with a pericardial patch. The length and width of that patch is determined by these silk sutures. Though I took intentionally up to P3 zone, but later on I realized it was still falling short. The PML was not coopting well. The patch is inserted into that gap. This is the final view of that PML plastic. On testing, but it is still, MR was still persisting. As you can see, from a post-middle segment. So did that Wooler stitch, which we all hate, but we all put. And commissuroplasty and sutures were tied with Hager dilator in so that I don't produce metal stenosis. But still MR was persisting. And we saw that this posteromedial area where there is a gap which was not able to fill despite PMLplasty and commissuroplasty. So did a commissuroplasty, patch commissuroplasty. So the final view of repair after caudal plication, PMLplasty and commissural patchplasty and commissuroplasty and partial annuloplasty. This is a picture. So now you can see it's hardly any MR. It's another patient with the competency check, caudal plication, and it's only caudal plication. The AML was not that prolapsing, so it's hardly any MR in this patient as well. So atrial septum, subdermal sutures is being closed. The same patient heart falls back into the cavity and there is no distension of LV. This is that girl with bileaflet prolapse and multiple chordae elongation. It did new chordae insertion, caudal plication, bileaflet plasty, resection and plasty, and partial ring plasty, partial annuloplasty. There is no MR. She's 7-year-old. The same patient come back after 1 year. So no MR. It's tiny jet. Hardly any MR. The patient with underwent PML plasty and commercial patch plasty and caudal plication. You can see there's hardly any MR. So one failure probably I will call it because patient will perioperatively is hardly any MR, but pre-discharge echo showed MR and probably you are discussing some malignant kind of thing, eccentric jet. But patient is doing fine and is on medications. So the first case we did about 13 years back. That time patient was 9 years old and now it's 22 years old. We only have echo at that time. We don't have like such mobile cameras. You can see the dilated annulus and the AML is prolapsing, leading to severe multiple jets, MR jets into the LA. So you can see the AML is rolling into the LA. So we did multiple artificial chordae implantations and posterior reduction plasty. This is 7-year follow-up. Right now, is almost 13 years post-op, is doing fine. So no MR. So our outcome in our series is no early or late mortality in the follow-up of approximately 1 to 13 years. No trivial MR in 3 cases, mild MR in 4 cases, only one moderate MR, residual MR in 1 patient is stable on medications. So conclusion is the mitral valve repair of Marfan child offers a huge challenge to the surgeons. The risk of recurrence is more with pronounced bileaflet prolapse and multiple chordae elongations. And there's a risk of potential remodeling of left ventricle if baby also has significant aortic valve and root dilatation issues. So, but if you combine many techniques and desired result and desired intermediate term outcome can be achieved. Thank you very much.
Any questions from the audience?
One thing which my thinking is that I think we have to be a little bit more liberal with artificial cords in these patients because while some of my patients whom I had initially tried avoiding, I did get MR because the leaflets actually elongated, in fact, in other areas. Therefore, in other areas which were not this thing, in some of my patients whom I had followed up. This was around 15, 16 years later. If we had operated on P2 or A1, A2, the A3 was this thing. That's why now I tend to put 2 prophylactic strut chordae in the thing and leave it because I felt you are not dealing with normal tissue. And tomorrow the AR will also occur. So you need to fix it properly the first time. That's one.
If the cord is strong enough.
But what I'm saying is this happens over a longer period of time. They were all looking good initially, but somewhere around 14, 15 years later, they started developing.
The growth and the question remains as far as the.
Yeah, but now we know the data that artificial cards in that age group.
No, but if it is thin, then it must use the artificial cord, but not like using. But one can use the
but many of
strong
these
one.
fillers look thick,
One
but
of
they're
the
not
strong
normal.
ones.
Only one question from the cardiology perspective. Basically, it's a genetic disease or incorrectly disorder, so it's expected to be progressive. So, what happens over the period of time on long-term follow-up?
So far, like if you take a median follow-up, is approximately 3 to 5 years. So we haven't found any patients coming back for the, like we were surprised to see that this patient has developed. He was very good. Like only one patient who developed MR even within 7 days. So that probably is first switchers might have given up. Otherwise, in 5 to 7 years, nobody has developed what we were not expecting. Though we are expecting in this particular girl with so much of leaflet prolapse, but last 3 years she has also done well. So let us see, but it's still better than MBR.
Thank you. I think those were.
I think,
Yeah, sorry.
so
go-
please.
No, go ahead.
We're getting late, sir.
Yes, I was just going to say excellent questions, excellent videos. I think it was nice to see multiple techniques that you used on one valve to make it competent. And I think we'll move on to the next talk. So thank you.
Okay, thank you very much.
Thank you, Dr. Sunil Kaushal, for taking us to the gamut of techniques to deal with the mitral valve incompetence in the myxomatous mitral valves. I'm privileged to call upon Dr. V Devagourou, Professor CTVS at AIIMS Delhi, to present his topic, mitral valve repair in children with acquired heart disease.
देवगुरु इसको कैसे करना है?
So this is from this is.
Good morning, distinguished chairpersons, esteemed colleagues, and dear students. From excess tissue, we'll move on to paucity of tissue. I'll be talking on acquired heart disease, mitral disease in children. When it comes to acquired, there are few reasons we can have. One is infection, endocarditis or myocarditis. The second is inflammation. The classic is rheumatic heart disease. Then we can have structural or ischemic. In children, what we get most common is the rheumatic heart disease. This is the cartoon of the structure surrounding the mitral apparatus. So it's important to know when you venture into mitral valve repair. It shows the relations of the two cusps of the aortic valve and the circumflex artery and the coronary sinus, plus the two trigones. It's very important to know both the trigones when we are measuring for using the rings and also for placing posterior annuloplasty rings. These are the common terms we use. Dr. Anderson had described as mural and anterior aortic leaflet, but commonest is anterior leaflet is aortic leaflet and the mural leaflet is the posterior leaflet. We have two clefts in the posterior leaflet, divides the posterior leaflet into three segments, P1, P2, P3, and the corresponding anteriorly we have A1, A2, A3. In addition, we have the two commissures, anterolateral and posteromedial commissure. In the inset, we see the plane of the annulus. When the leaflet goes beyond the annulus, we call it prolapse. The annulus is a structure, not the junction between the valvular tissue and the atrial wall. It is deeper to that. This is the annulus. The cartoon shows the distance between the valvular junction and the annulus. The sutures have to be placed in the annulus to have a firm support. To make it simpler, the chordae are divided into primary, secondary, and tertiary. This has had some relevance in the treatment because
most often in rheumatic heart disease, we'll be able to manage transfer of the secondary chord to the primary position, because in rheumatic heart disease, the secondary chord is strong and stout, and they are not elongated. Unless the myxomatous or ischemic, we can make use of the secondary chord. This is the simplest classification of the chord: marginal of the primary, intermediate secondary, and the tertiary chord. As far as the classification, class 1, when it comes to endocarditis disease or long-standing MR, will have the annular dilatation. In endocarditis, we can have punched out lesions in the anterior leaflet, or you can have vegetation in the orifice which can produce MR. As for 2, classically what we get is a pseudoprolapse, not the real prolapse in rheumatic heart disease. We have a pseudoprolapse of the anterior leaflet and restriction of the posterior, that is 3, restriction of the posterior leaflet during diastole. There are some fundamental principles of repair, and why we have to repair. Dr. Kalangos has already addressed what is the advantage of having a repair or a replacement in children. The principles are same as in the adults. We have to preserve or restore the normal leaflet. Then we'll have to create a large surface area of coaptation, and we have to support it with some annuloplasty, some form of annuloplasty. As Dr. Muralidhar Kanchi addressed the importance of TE for assessment and post-op repair assessment. Then usually in children, we prefer median sternotomy. Those who are doing minimal access, or if you want to give a cosmetic incision, you can have anterolateral thoracotomy with equal effect. As for the approach, it depends on how much is the LA dilated. Most often we go through the LA, or if you can have a biatrial approach. It is routine to assess first. Once you open, you have to assess. And these are the various forms of annuloplasty for the type 1 lesion. The commonest we do is a posterior annuloplasty in children, either using a Teflon felt or a pericardium. Sometimes we can use some smaller annuloplasty, a segmental annuloplasty, or a Magoon stitch can be used. Sometimes at the commissures, we can use a K-Ola stitch. As for the prolapse of the anterior leaflet, we have various techniques, out of which the easiest and simplest to use in rheumatic heart disease is the chordal transfer. Even if you're putting artificial chordae, if you can identify a good secondary chordae, transfer it to the primary position, that gives an idea of length to which you can adjust your artificial chordae. Of course, you can have chordal shortening at the papillary level muscle or at the cuspal level. This is the chordal transfer from secondary to primary. I'll show some videos of some of these techniques. Then we have, in children, we may not be able to transfer a secondary chordae. Then we may have to move tissue from the posterior leaflet with a bunch of chordae anteriorly, and the posterior defect is treated like a prolapse. This is how we do at the cuspal level, and Dr. Sunil showed at the papillary muscle level and also at the cuspal level. This cuspal level shortening was popularized by Professor Sampath in rheumatic heart disease. This is the computer-generated model of chordae. So what are the materials we can use for chordae, artificial chordae? They have tried everything, but the EPTFE stood the test of time. There are several techniques, as we know, since it's not standardized, there are almost 27 described techniques of adjusting the chordae. The simplest is to adjust with the 2 right angle hooks and make a knot and put a liga clip on top. Or you can use, like Dr. Kalangos showed in the previous lecture, or you can use the Adams technique where you do a double surgical knot so that it doesn't slip when you're tightening. You test it with a fill the left atrium, left ventricle, and look at the coaptation and adjust the length of the chordae when there is no leak. He uses a double surgical knot, or you can use a pericardial felt so that the stitch doesn't slide. I also have a small video of a simpler technique. This is one. In children, we use 5-0 PTFE suture. In adults, we use 4-0. Sometimes we may have to use 6-0 also PTFE. Look for a fibrous part in the papillary muscle. Use a pleated suture. Bring it through the prolapsing segment. Use 2 right angle hooks corresponding area on the posterior side, which is not prolapsing, or you use the P1, P2 junction. Adjust the length. Once you're sure, you put a small liga clip, 100 mm liga clip, gently so that it doesn't weaken the suture. On top of it, you keep tying knots and remove the liga clip at the end of the knots. Always there's a concern of using the artificial cord in children, whether it's going to grow or not, whether it's going to restrict. But this is a long-term 17-year follow-up, which Dr. Kalangos also showed. They have shown there is a compensation from either the tissue itself, valvular tissue, or from the papillary muscle, which adjusts the length. This is they have a 93% freedom from reoperation at the end of 15 years, 10 years. The concerns I already said, whether it's going to restrict or it's going to compensate. As for type 3, it is similar to what we do in adults. In type 3, sometimes in one of the other acquired diseases, when there is a obstruction below, we can have a supravalvular membrane also. In a real rheumatic population is similar to what we do in adults. We have to take care that we don't extend the incision towards the annulus too much so that the segment becomes flail. You will have to address the thickening of the leaflets by cuspal thinning. Then we'll have to have a commissurotomy. Then we'll have to do a papillary muscle splitting. Sometimes in heavily subvalvular diseases, then we may have to fenestrate the thickened and fused chordae. This side shows the cuspal thinning. The bottom one shows the cuspal thinning. So if you can remove at least from the posterior leaflet, which is most often restricted, you will have at least some length of PML, and it allows it to move freely and good cooptation can be achieved. And if there is no dilatation, then there is no need for a annuloplasty. If there is dilatation, it will require an annuloplasty support. Sometimes we may have to augment the posterior leaflet, especially as I say, that there is positive tissue in rheumatic heart disease. The inset shows elliptical shape of pericardium. If you do like this, sometimes there is a diastolic gradient. So to avoid this, we should have a quadrangular shape of pericardium like this, which prevents it's called aortic cuspify. So for it to open, you should have a triangular. And there's a video I'll show of all these techniques. This is one child. We thought it was congenital, so we took for repair. This is a secondary chordae which we are transferring. Usually they have good secondary chordae. Even if I want to put a artificial chordae, this will give a guide to the length of the artificial chordae. Then we look at the PML. It's completely plastered. After cuspal thinning also, there is hardly any PML left. So we decided to augment the PML. The trick in augmenting is you'll have to go from commissure to commissure. There's no point augmenting little bit. You'll have to augment commissure to commissure. And as I said, you take a rectangular piece of pericardium measure with a silk thread and take a adequate size of pericardium and make sure it is at least 1.5 centimeter in breadth. And you go from commissure to commissure. In between, you lock to prevent purse stringing. Then this being a child, we use the pericardium. We try to keep the shiny surface outside. And if the procedure is going to be long, then you preferably test the valve using cardioplegia. Especially now that we have started using Delnido, it's better to test with cardioplegia so that you don't wash off the cardioplegia every time you test. What are the results we have in rheumatic population in children? Dr. Sampath had a series of papers committed to mitral valve repair in children. The actuarial survival was very good. These are the two papers. The actuarial survival was very good. The techniques used are, as I said, unique was the cuspal thinning and of course the caudal shortening at the cuspal level. These are the techniques used and the outcomes are very good. Actuarial survival at 15 years was 93%. And freedom from pre-operation and event-free survival also was very good. There are other papers also, one from the Australian group, Krishnanaik. They have found some risk factors for reoperation. One they've said is the mobility of the anterior leaflet and of course the use of the augmentation of the posterior leaflet. These two are the major risk factors. Of course, Professor Kalangos will delve on this in his coming speech. And Dr. Srirup and Dr. Bose have a review article on this from Durgapur, and they've addressed all the problems in rheumatic mitral valve repair. So MV repair in children is effective and satisfactory long-term results. As Professor Kalangos said, we are just doing some palliative. You at least postpone the valve replacement. The problem of valve replacement is higher morbidity, higher mortality. The implanted valve size will not have right size. And as far as bioprocesses, there is early degeneration. Of course, the life expectancy decreases only by use of anticoagulation. Summary mitral valve repair in children is feasible and it's durable if you keep attempting and use the right technique. Thank you.
Should we take one question? Any questions?
Thank you, Dr. Devagourou, and of course, your extensive experience on the rheumatics with mitral valve lesions. Now, the question arises with the annuloplasty technique. Now, what is the current annuloplasty rings that you're using in the rheumatics? Do you still use a classic ring or you're going to the physio?
We used to use classic ring. Presently, classic is not available. So we use the physio ring, physio 2 only. So if any child will allow a 28 ring, then we'll prefer to put a ring.
The most important point, especially when it comes to, of course, we want to preserve or use the natural tissues for caudal replacement. The problem in the rheumatics is you have this lesion of the 2A, 3B lesions. And this becomes a challenge, especially when you want to do a transposition technique. So would you give your thoughts on that? Which is better? So using artificial cords.
The Carpenters group extensively used transposition. I've been in Vietnam for 6 months. Dr. Phan and Feng used transposition only. Of course, once you start using a prophylaxis, probably the secondary chordae may not elongate, and they always support with the annuloplasty ring. Even if you are not using secondary chordae, at least primary as a primary modality, if you can transfer a secondary chordae, that gives a very good judgment for your placement of the second artificial chordae. That's used by Adams quite often.
One last point question is regarding the coaptation height. How much is acceptable? Because we, you know, in the adult, adults it's very well established. But in pediatric, this always is a question: how much is really acceptable coaptation height?
I think it should be 4-5 millimeters should be quite enough at the center.
Yeah, Dr. Devagourou, we have an online question by Dr. Ratan. Is there a role for subvalvular repair in case of Alcapa with MR?
Alcapa with MR, subvalvular like ischemic heart disease, moving the papillary muscles like extensively what we do in ischemic heart disease. I don't think we do at all.
Okay. Thank you.
Thank you so much. I think we'll move to the last talk for this session. Dr. Kalangos.
There will be no official tea break. Tea is being served outside. I think in between we need to go and have, because we are running already short of time of 30 minutes plus.
I'll just make one announcement. The Google feedback forms will be released at the end of the session. Please feel free to give your valuable suggestions, and the certificate for participation will be given only once we receive your feedback forms. Thank you.
Yes, time is running down.
So this rule is done just to improve ourselves, sir. Thanks.
Yes. As time is running out for Tizen, I will go quickly through the durability issue of mitral valve reconstruction. Okay, regarding the different etiologies of the mitral valve diseases in children, there is 4 main etiologies: the congenital, the rheumatic, endocarditis, and the degenerative. But it doesn't function. Yeah, and there is 2 techniques: repair versus replacement. Now, regarding the durability, there is the early durability and there is the long-term durability. And then, you know, when you kindly asked me, you know, to present the durability issue of mitral valve reconstruction, I went back to my results and checked what I made wrong. And finally, you know, I analyzed all these factors and I decided, you know, to start with this slide because this one is important. Is, you know, especially, you know, for a surgeon during his initial stage of his experience with mitral valve repair techniques, is very important, you know, to pass also this information to the audience. First, you know, there is errors in judgment with attempts to repair an irreparable valve. You know, because as I was trained by Professor Carpentier, I passed, you know, I spent 5 years with him. And each time, you know, when he was replacing a mitral valve, you know, he was telling me, I feel myself very frustrated. And usually, you know, he was excising the valve and leaving me to do the remaining part. And then I was, you know, as a young surgeon in the same policy. And again, I was trying to repair, you know, an irreparable valve, the first mistake I made in my career. And then the suboptimal repair at the time of initial surgery, they are, you know, the technical failures. And usually, you know, the suboptimal repair is due to the inadequate analysis of different valvular and subvalvular lesions, to the inappropriate selection or application of some repair techniques, and sometimes, you know, to the failure to perform concomitant annuloplasty during the initial repair. The third factor is to be obliged to do something during the ongoing rheumatic activity at the time of surgery, acute carditis in rheumatic carditis. When you have, you know, a significant mitral regurgitation creating hemodynamic instability, you are obliged to do something. And as I will show you, this one is a risk factor, even affecting, you know, the early durability. And then is the type 3 dysfunction with extensive mixed fibrotic lesions. If, you know, you are leaving the operating theater with a post-repair mean transmittal gradient above 8 millimeter of mercury. Be sure that in very early stage, you will be obliged, there is a high probability to reintervene. Now, we start, with the durability in congenital etiology. This one is an important paper coming out from Stelin. He was the chief cardiac surgeon in Padua. And he published in 2010 the surgical repair of congenital mitral malformation, single center, 30 years experience. And as you see here, the survival, I will tell you now, excellent, 75% and at 36 years, as well as the freedom from reintervention, 77% at 36 years. With this paper, I have a problem because unfortunately I didn't obtain the same results regarding the congenital mitral stenotic or mixed lesions. And in his personal experience, Professor Stelin published that there was no statistical difference between the regurgitant and the stenotic groups. Then the other important series belongs to Carpentier regarding the congenital mitral insufficiency. And it was published by Chauveau in 1998 in the Journal of Thoracic and Cardiovascular Surgery. And they compare the congenital repair group with the replacement group. And as you see, at 10 years, the survival was 86% in the repair group and 51% in the replacement. It's obvious that repair is better than replacement, in terms of survival. And then regarding the freedom from reoperation, at 5 years, 86%, 10 years, 80%, and 15 years, 68%. Now, I went back to my experience, 167 cases, the mean age 3.2. And in terms of insufficiency, I'm very close. And this one is the honest version of my personal experience. At 10 years, 62% of freedom from reoperation for the regurgitant group. But look, the mixed and stenotic group, as you see, is 47% at 5 years. When you have a stenotic valve mixed pathologies, as I said also to Sanjay, this group really, you have to buy time. The mitral valve repair, you have, at the beginning, be sure that it will be a bridge operation for a late replacement. Now, regarding the durability in the rheumatic group, again, one of the biggest series belongs to the Carpentier's group, published again in Circulation by Chauveau in 2001. As you see here, the survival rate is quite good, excellent, I will say, in case of repair. At 20 years is 82%. Regarding the freedom from reoperation, the reoperation rate is 2% per patient per year. And at 20 years is 55%. The freedom from events, and because they included also the episode of atrial fibrillation and all the thromboembolic complications related to atrial fibrillation, or the hemorrhagic complications related to the episodes of atrial fibrillation, because they put the patients under anticoagulants and so on. Here, this part also, this factor also affected the freedom from event. As you see here at 20 years, it's 52%. And then they noticed that the freedom from reoperation is better in the prolapse, anterior or posterior or both leaflet prolapse. than the restricted group, the type 3 group. And in the type 2 group, in the prolapsing group, the reoperation rate is 1.9% per patient year, and in type 3, in the restricted motion group, is 2.7% per patient year. And then they took the subgroup of patients younger than 19 years of age. And then here, as you see, the freedom from reoperation at 20 years, 54% is not different compared to the whole group. And then they checked also the subgroup of patients operated on during the acute phase of rheumatic fever. And here the results are not good, neither in terms of survival, nor in terms of freedom from reoperation. The survival in this subset of patients at 20 years is 65%, and the freedom from reoperation, catastrophic, at 20 years, 55%. And regarding our retrospective study, in our group, it was the mean age 11 years, and the survival was quite good, 98% at 17 years, and the freedom from reoperation, 80% again at 17 years. Again, in our experience, we had, the same results as in the Carpentier's series. There was a statistically big difference between the type 3 group in terms of freedom from reoperation and type 2A anterior, the anterior leaflet prolapse, or the anterior leaflet pseudoprolapse. It was, a new definition, because when you have a restricted motion of the posterior leaflet, the anterior leaflet goes to the level of the anterior of the annulus, but doesn't override the annular plan. This one is the pseudoprolapse, because there is restricted motion of the posterior leaflet. You have the impression that the anterior leaflet is prolapsing, but it doesn't prolapse because it doesn't override the annular plan of the mitral orifice. And for this, I put a new definition as type pseudo anterior leaflet pseudoprolapse with restricted motion 3 posterior. And as you see, there is a statistically significant, and type 1, in type 1, the annular dilatation usually occurs during the acute carditis. And this one intervened during the stage, as in the Carpentier series, is a challenging condition with very bad results in early and long term. Regarding the durability in endocarditis, there is, a very good paper which was published by the team from Melbourne, as you see, Christian Brizard, again from who was one of the members of the Carpentier's team. And the mitral valve repair in children, as you see, there was, a lot of cases involved in the study. And they concluded that the mitral valve repair is feasible in the majority of children, and then survival is excellent. Approximately 2/3 of these children are free from mitral reoperation, and 80% are free from replacement at 10 years, and 70% are free from replacement at 10 years. The risk factor for them was the large vegetations, and these vegetations were related to an increased risk of embolic complications. Regarding the durability in the degenerative and connective tissue disorders, as the previous speaker, Dr. Sunil presented, there is no big series, there is small case reports or, some case reports series and so on. We cannot present the long-term results. And for that reason, I prefer, to show the very long results of Carpentier's team with the degenerative pathology. I cannot, it's blocked. Okay. Published again in Circulation in a very good journal in 2001. And as you see here, compared to the expected survival, the freedom from cardiac death at 20 years is 81%, is very good. And the overall survival was 47%. Regarding the different types of lesions, the posterior leaflet alone, in terms of freedom from reoperation, has the best results in 20-25 years compared to the anterior leaflet prolapse or both leaflets prolapse. In conclusion, we can say in rheumatic mitral valve disease, the survival is high, but long-term stability is poor due to the progression of the inflammatory process. Pre-operative findings of a restricted motion of anterior mitral leaflet and repair during the active inflammatory stage are negative predictors of repair durability. Regarding the congenital patients, the survival and long-term stability are high. Younger age, mixed and stenotic valve disease, early residual mitral regurgitation, more than moderate, suboptimal repair, inherent complexity of the disease, especially in dysplastic leaflets, are risk factors from freedom from reoperation. And usually early valve failure usually happens within the first years of surgery. Regarding the endocarditis, based on this excellent paper, we can tell that the survival and long-term stability are excellent. And big vegetations, bigger than 1 centimeter, is a risk factor for embolic complications. And regarding the connective tissue disorders, long-term stability of mitral valve repair is high. Anterior leaflet and both leaflet prolapse are negative predictors of repair durability in adult cases. We wanted to extrapolate to the pediatric group, but this one we have to wait and see bigger series coming out. And the survival is also, don't forget this one, because this connective tissue disorders, as you presented, are part of some syndromes, and the survival is also influenced by the complications due to these syndromes. Thank you.
Thank you, Professor Kalangos. Excellent paper, good results. And I'm sure that you will agree with me that it has been a very useful presentation and good discussions. And I must thank the people who have taken part in this online also. Anyway, thank you very much. We all will break for tea. Right?
Yeah, there will be no tea break because we have to continue. If you would like, you can go relax a little bit and come again back, because otherwise we will be late for the inaugural session. Yes. If you are tired, you can go for some minutes and come back.
I think we can assemble in 5 minutes, sir. I request, please. Yeah, any cast, we'll go ahead with the next session, please.
We could quickly move on to the next session, session 2 on aortic valve. I invite the chairpersons for the session, Dr. A. Kalangos, Dr. V Devagourou, Dr. Ganpati Subramaniam, Dr. Ragini Pandey, Dr. Minalindu Das, and Dr. Devasis Das. Requesting the faculty members to please come on dais and chair the session for the aortic valve. Okay. Carlos A. Mestres, he will be chairing the session online.
Hello, good afternoon.
Yes, welcome to the second session. And we will start again with Dr. Anderson with the first presentation, the aortic root complex, anatomy and pathology in children revisited. Dr. Anderson. Is connected, Dr. Anderson? Do you know?
So we have his pre-recorded presentation.
That's pre-recorded, okay.
It was pre-recorded or recorded? Okay.
So we move on and we now look at the anatomy of the aortic root.
Kindly make
What I'd
it
like to
full
emphasize here is that the aortic root is the centerpiece of the heart. I've been able to see that for a long time. You can now see that with the wonderful computed tomographic data sets you all have at your disposal. So here is a lovely computed tomographic data set from normal heart prepared by my good friend and colleague, Justin Tretter. And as you can see, Justin has segmented the hinge lines of the 4 cardiac valves. And there you see the hinge lines demarcate the aortic root, and it is centrally positioned within the short axis mass. Superiorly and anteriorly, we find pulmonary root, again with semilunar attachment of the valvular leaflets, something that we are going to emphasize as the features of the arterial valves. There at the back, see the mitral valve, front of that, tricuspid valve, and the aortic root is wedged between the 2 atrioventricular valves with a significant infraseptal recess. So let's look now specifically at the aortic root. We have a potential problem how we describe the aortic root, and this was emphasized in this work here now 12 years ago from the group of German surgeons who sent out a questionnaire to worldwide cardiac surgeons to determine how they all describe the aortic root. And as you see, the conclusion was it was a Tower of Babel, because no one was using exactly the same words to describe the root. So we have to make our way through this confusion and work on something that is going to work for all of us. And I believe here that is to describe the leaflets as the moving components of the valve, as we did for mitral valve. And we need to distinguish the leaflets, sinuses, as I'm going to show you. The key feature of the arterial valves is that the sinuses house the leaflets in semilunar fashion. But again, as the atrioventricular valves, we have zones of opposition between the leaflets, and that is the areas where they come together when they are closed. When we consider the arterial routes, however, there are additional areas to which we need to pay our attention. And for both the aortic route, pulmonary route, which we will discuss in time, it is the sinutubular junction that marks the distal extent of the route. The proximal extent is more controversial. And this was another feature that came to emphasis during the account of German surgeons, because that proximal area is a virtual basal ring. And again, I'm going to show you that. But I'm also going to concentrate on the interleaflet triangles, because it is the arrangement of the interleaflet triangles that is the key to understanding the valve when it is congenitally malformed. So let's go back to the parasternal long axis cut, and let's look at the extent of the aortic route. And as you see, being the centerpiece of the heart, it is sandwiched between the left atrium posteriorly, the infundibulum of the right ventricle anteriorly. And the key feature of the route is the semilunar attachment leaflets, which are attached distally at the sinutubular junction. But look at their proximal ends. There is no anatomic structure that is supporting the proximal ends of these semilunar leaflets. And this is no more than a virtual basal plane, but this, of course, is the area that the echocardiographers describe as the valvar annulus. It's only when we open the valve, we as morphologists get a full view of what's going on. And now you see the sinuses. That is the right coronary sinus. Diane Spicer, who made this beautiful picture, cut through left coronary sinus so as to open the valve. And there we have the non-coronary sinus. And now you see that within the root itself, 1/3 of the root has myocardial support, that is supporting the two sinuses that give rise to the coronary arteries. But the larger part of the root has fibrous rather than myocardial support. And this is a key difference, as we will see, between the aortic root and pulmonary root. But let's close in on that area that has fibrous support. And now you can see the interleaflet triangle, specifically the interleaflet triangle separating the right and the non-coronary sinuses. At the base of that triangle, we find the membranous septum. To the back, we see the area of fibrous continuity between the aortic root and the mitral valve, and that is thickened at both of its ends by the fibrous trigones, left and to right. But when you look carefully, you now see that there is another area of fibrous tissue interposed between the rightward end of fibrous continuity and the septum. And this is the inferoseptal recess. And the inferoseptal recess is roofed by an area of fibrous continuity between the leaflets of the mitral and tricuspid valves. And that is not strictly part of the aortic root, but it is an important component of the left ventricular outflow tract. Nowadays, of course, using computed tomographic data sets, you can see the area much better during life, and I can show you in the autopsy heart. So again, thanks to Justin, I can share with you these beautiful computed tomographic images. And here we're looking down on the aortic root, and you can see the circular sinotubular junction. To your left hand, See the left coronary artery telling us that that is a rising left coronary sinus. And to your right hand, right coronary artery tells us that we're looking there at the right coronary sinus, meaning that the third sinus is non-coronary. That is the furthest part relative to pulmonary route, so I like to call that the non-adjacent sinus. The virtual basal ring is more elliptical and doesn't match exactly the circular sinusoidal junction, and that shows us that at the base of two coronary aortic sinuses we have myocardium. We can see the same thing if we look at the route from behind, again as segmented by Justin. And now in purple, Justin has shown you those interleaved triangles. We're looking through the triangle that separates left coronary sinus, non-coronary sinus, and anteriorly, he has marked the location of those myocardial crescents. And they provide the myocardial support for the two coronary arterial leaflets. And they are the focus of electrophysiologists when ablating arrhythmias arising in the outflow tract. And this is where we get problems with the use of the word cusp, because the electrocardiologists suggest that they are ablating within the cusp, and they don't mean the leaflet, they mean the base of the sinus. And that is why I believe we need to distinguish between the leaflets and the sinuses. The leaflets, of course, close. Diane Spicer has made this lovely image showing you the leaflets in their closed position as seen by the anatomists. You're looking at it from above, so we see the right coronary sinus, the left coronary sinus, and the non-coronary or non-adjacent sinus. We see how the leaflets come up to the sinusoidal junction at their peripheral attachments, but the center point of the closed leaflet is well down within the root. And that is important for those of you who repair the root. And this image made by my other good friend, Shaun, shows you the location of the sinusoidal junction, virtual basal plane, and how now you can make measurements to show you what is going on in the normal as opposed to the abnormal part. You can measure the height of the interleaflet triangles. You can ascertain the free margin of the leaflets, permitting you to determine their effective height and similarly their coaptation lengths. And it is this information that gives you what you need to know when you are repairing the malformed valve. And again, to emphasize, when you look at the malformed valve, the significance of those interleaflet triangles. Because I believe it is concentration on the interleaflet triangles that permits you to distinguish the phenotypic features of the valve when it is abnormal. So most of the valves are trisinuate. But as you all know, within that trisinuate scaffold, we can have two functional leaflets giving us the so-called bicuspid valve. And we find that when most usually the right and left coronary leaflets are conjoined, oftentimes it is the right and the non-coronary leaflets that are conjoined. Rarely the left coronary leaflet can be joined with the non-coronary leaflet. But if we look carefully at the number of sinuses, we can also find, particularly in children, that we have a trisinuate valve with only one functional leaflet. And then, as we concentrate on sinuses and leaflets, we can find the rare arrangement in the bicuspid valve where there are not only two leaflets, but the leaflets are supported by only two sinuses, and very rarely we can have four leaflets, four sinuses. Again, we see these beautifully now when we use computed tomographic data sets. Another beautiful image prepared by Shaun, who now works in Los Angeles. Initially, he was from Japan, and he shared these images with me quite some time ago now. But he's showing you here the arrangement with the large non-coronary sinus, conjunction of the right and left leaflets, but in the setting of a valve with separate right and left aortic sinuses. So trisinuate, but bifoliate. And now in Diane's lovely image, I can show the arrangement that you see most frequently in children. Look at the sinuses, first of all. We have a solitary commissure at the sinutubular junction, and that is between the non-coronary and the left coronary sinus. There is the left coronary sinus, right coronary sinus, and look at the hinge line of the leaflets that are supported by the two coronary sinuses. They are no longer semilunar. And in fact, the feature of the trisanuate valve with a unifoliate arrangement is the lack of semilunar attachments of the leaflets. And this is the valve that is most stenotic. And to me, this introduces the concept of the annular paradox. Many of you think of those semilunar attachments as representing the valvar annulus, and it is then a paradox that the normal leaflets are hinged in semilunar fashion, and they lack an annular attachment. When you see a true annular attachment, as I've just shown you in the setting of the trisinuate but unifoliate arrangement, then the most severe is the degree of valvar stenosis. Before we finish with the aortic root, let's remember the relationship to the atrioventricular conduction axis, particularly important to you surgeons, and we can do no better to determine this. Look at this exquisite image prepared by Sunil Kaushal when he first described the atrioventricular conduction axis now well over 100 years ago. He's opened the left ventricle, shows the non-coronary leaflet, the right coronary leaflet, and then having marked in the atrioventricular conduction axis, sandwiched between the membranous and muscular septum, he shows the area of major danger is the nadir of the semilunar attachment of the right coronary leaflet. So what I've shown you in this discussion of the aortic root is now using computed tomographic data sets, you as clinicians can see all of this detail just as well, if not with more detail, than I can show it you in the dissecting room. But it does emphasize again the need to use terms to describe those components of the root that are meaningful for everybody. Thank you.
Yes, I would like to thank Dr. Anderson for having reflected his very precious experience. We will continue with the second presentation. I believe there will be no question because it's not connected.
So we call Dr. Baiju, for surgery of aortic valve endocarditis in children.
Can change it. Good morning, respected chairpersons and friends. I would like to thank Dr. Hiramat for this wonderful opportunity. And I would like to start by paying homage to the teacher of my teachers, Professor M.S. Muralidhar. He is the man who made the institute I have been associated with the last 25 years. And we will miss him. Aortic valve endocarditis. For that matter, endocarditis in any valve can be relentless. It may haunt you, especially when you try to cut the corners. This is the story of a 13-year-old boy who had a VSD closure with aortic valve repair in 2013. And 5 months later, he had infective endocarditis with root abscess, and he presented with a systemic embolization. So we went and replaced the aortic root with a homograph, but the infection seemed to be far away from the VSD patch, and maybe earlier in my experience, we left it like that. He came back with a pseudoaneurysm of the distal anastomosis. This is the pseudoaneurysm. And 6 months later, again, we did firefighting. We just repaired the pseudoaneurysm, and he came back again.
we did a supracoronary aortic arch replacement, ascending aortic replacement. He came back again with infected homograft. This time we knew there are no shortcuts. We went in and did a thorough debridement, removed the previous VSD patch and put a new homograft. At the same time, one of my residents found out that he had an ingrowing toenail, and we took a scraping from that, and it grew the same fungus as is grown in the aortic valve. So it's all important to look for a source of infection and do thorough replacement. And now 10 years is going on with the homograft. Now the homograft has started developing gradient, and I'm going to take a leave when he comes back. So the principles of surgery for aortic endocarditis is, of course, thorough debridement with irrigation, as I illustrated in that case. Aortic valve endocarditis has a propensity to have a much more extra valvular spread because of the high pressure zone. And there is no shortcut. We have to remove all prosthetic materials and implants and try to reconstruct with biological tissues. Homograft is a surgeon's friend in an aortic root endocarditis because it offers you a lot more tissues to fill in the cavities and correct the hemodynamic abnormal. You could use an autograft also. We have used autografts also. Or I have no experience with stainless porcelain root. And correct any hemodynamic abnormality or the defect. And the prime thing is to prevent reinfection. We practically do it as two operations. The first step, you debride, do a thorough debridement, irrigate, then change your gloves, put a new set of drapes, get a new set of instrument, and do the reconstruction with the new set. That's the only way to prevent reinfection. And there is no point in sitting on a bad valve. A leaky valve will not become competent. A dead tissue will not come back, and we need to go in. And mind you, it's not the surgeon alone, or it's not the antibiotic alone. We work in tandem. And this is our experience of, luckily it's not so big, it's only active endocarditis. We had even higher number of patients who were operated for sequelae of endocarditis that are not included. Of these two patients had no valve involvement, had only ascending aortic involvement, and that is a demographic. We had 5 root replacements, that one patient had needed 2 replacements, so it becomes 4 patients. And we had one patient who had a prosthetic valve endocarditis. This is our epidemiology. It's predominated by methicillin-resistant Staph aureus. We had all organisms, including that fungus, Aspergillus niger in the case I mentioned initially, and one patient didn't grow anything in his blood culture. The indication for operation is extravalvular spread in most of them, pseudoaneurysm in 2, the systemic embolization in 1, and a couple of patients had cardiogenic shock, and there was a heart block also. The surgical challenges, of course, one is most of them were reoperations, so safe re-entry is an issue because of the anterior aneurysms, and yet you have to debride thoroughly, but yet you need to maintain the anatomy and functional integrity, conduction system if possible, and prevention of reinfection is foremost important. This could be an example for this boy had a VSD closure elsewhere 4 weeks back and presented us with this. And here an MRSA and mediastinitis. And this was a CT scan. This is another girl, our own patient who underwent a BDG, had again MRSA, mediastinitis, went home, came back after a year with this. She had extracardia, as you can see, and a huge pseudoaneurysm. And all these patients will need thorough planning, and both of them are uneventful sternotomy and went home without an issue. I have videos, but I have deleted it for want of time. This is another 9-year-old boy who had a small BSD, was on medical follow-up, and he had septic arthritis and had grown MRSA in blood. And he presented to us with this vegetation in the BSD on the RV side and with severe aortic regurgitation. And if you see carefully, is the pointer working? No, it's not moving here. Okay. And you can see that. Can anyone help me? You could see that small root ups. Sorry for that. I would need that. Yeah, thank you. So you could see a small bulge here in the right sinus. Here, better be. Here it's more evident in the intraoperative TE. You see the right sinus is destroyed. The annulus is destroyed at the right sinus, and you got severe aortic regurgitation. This is the intraoperative image, and the aorta is transected. Go a little further. We are excising the valve, and that's the right coronary button excise, and you see the whole area under the right coronary is ruined by an abscess. We are debriding. And this patient, we did a rose. We are harvesting the autograft. And now we are reconstructing the annulus with a bone pericardial patch there. %50 of the annulus anteriorly was destroyed, and we had to reconstruct with the pericardium, and then we put the autograft. We're putting the autograft into the reconstructed pericardium. This boy did well, and this is the postoperative echo. You see there is no aortic regurgitation. Ventricular function is good, and the conduit across the RVOT looks fair. Again, the postoperative TE. I'll just rush through this. This is another long story. A 9-year-old boy who had an arch repair and BSD closure elsewhere. Then he needed a balloon dilatation for coarctation, and we did a redo arch repair with LVOT resection in 2014. And then his LVOT gradients are minimal on discharge. Then gradually it came back, and we did a modified corner with he had developed mitral regurgitation, also mitral valve repair in 2017. And then again the same story repeated. He had more of a valvular aortic stenosis this time. We did a Rose corner with for the valvular aortic stenosis in 2021. He had no aortic regurgitation, aortic stenosis at the time of discharge. But he came back 1 month later with fever. The cultures were all negative. We did a CT scan. CT scan was normal. And echo showed a mild increase in the regurgitation. He went home with no AR, and he had mild to moderate AR at that time. He came back 6 months later with panophthalmitis. When we did a repeat CT scan, we see this destruction of the root toward the atrium. That was the entry point of his pseudoaneurysm. And this is intraoperative TE showing the aortic regurgitation. You could see the destroyed root there. And this being fifth stenotomy was not easy. We are trying to dissect the autograft out of the surrounding tissue. The autograft is excised, and now the left coronary button is being harvested. These are shot from overhead, that light camera. The quality may not be as good as some of other speakers, and I apologize for that. And this is the right coronary button being harvested. And now we are, after preserving the two coronary, we are excising, debriding the entire rest of the root. And that is the entry into the abscess cavity. I'm trying to excise as much as possible. Taking cue that is a cavity there, burrowing towards the endoatrial septum. And then we are just closing off the cavity, the destroyed part of annulus, with a bovine pericardial patch. And we used an aortic homograph to reconstruct the valve. He had no hemodynamic issues postoperatively. But unfortunately, his cultures didn't grow anything. And then he came back again with reinfection, and finally died because of septic shock. That's the one child I lost in this series. And this is another boy, 14-year-old boy with a bicuspid aortic valve with severe AS with small annulus. He underwent an aortic valve replacement with a posterior annular enlargement done by one of my colleagues. And he came with the prosthetic valve endocarditis, root abscess, and severe mitral regurgitation just 2 months later. He was in cardiogenic shock. He was taken as an emergency. And that is a CT which shows the extensive periaortic collection. And you can see the tissue all around the aorta is being destroyed. It's almost like an aorta is within an abscess cavity. It shows again the abscess area, the infection outside the valve. And he also had this issue. He had a drop lesion in the mitral valve. That is a hole in the AML with a mitral regurgitation. And again, we were to take him actually as a semi-emergency because he was very sick, not maintaining his pressures on a couple of inotropes. So the prosthetic valve is being excised. And that is after excision of the valve. The posterior patch, which is used to analyze the aorta, was enlarged. And this is a hole in the anterior mitral leaflet. And that was patched. And this is a thorough debridement, and after the debridement, we are trying to wash off, because one of our earlier patients had a minor stroke after a debridement, and so I make it a point that we wash off all the loose tissues. And here we are using an aortic homograft. And as you can see, I'm using the mitral leaflet attached to the homograft to cover the defect which was created for the root enlargement before. And this is some mild mitral regurgitation, not through the hole, through the central orifice, but it improved when the ventricular function improved. So our outcome, we had 2 reinfections, like both the patients as I mentioned, and 1 death because of the infected rose, and his culture grew and it didn't grow anything. So to summarize, infective endocarditis might need early surgery. There is no shortcut. We need to debride it thoroughly and try to reconstruct with the biological tissue. And culture negative is bad news because it is the antibiotic in tandem with surgeon which helps in infective endocarditis, and you don't know which antibiotic to use, you are bound to have a problem. Thank you for your patience.
Excellent presentation, Baiju. I think Carlos is one of the chairpersons, and he wanted to make a comment before physically present. Yes, Dr. Carlos.
Thank you very much. I think the previous session was excellent, and this is also excellent considering the contents. And I have a couple of comments. I think infective endocarditis is even more challenging in children than in the adult, and you know that in the adult is bringing a lot of problems. But I think that the point here, according to the microbiological data you showed from your series, is that all these patients, they have a high likelihood of coming back because all these pathogens are biofilm forming pathogens, which is what makes things very different and difficult in terms of diagnosis and surgical treatment. So you have to be commended for all these major efforts in saving these children, although you lost a couple of them. So my question is, you are right that culture negative is a major issue. However, my question is if you used genomic sequencing in these patients, because we know now that 16S or 1921S is actually bringing a higher yield of positive diagnosis. So this is my question, if you have already implemented that or you think to do it in the future.
Yes, these days we do PCR and the genomic sequences if the routine culture doesn't grow anything. But unfortunately, in our setup, it takes a bit of time. And this particular boy became too sick before we could In fact, we couldn't grow anything also. They did for that atypical organisms like chlamydia and all those gene sequencing. And they did a PCR for atypical organisms, but unfortunately, none of them were conclusive.
Well, thank you very much. And finally, I would like to personally thank you for briefly having paid tribute to one of the luminaries in Indian science and surgery, Dr. M.S. Valyathan. I thank you very much for that. Thank you.
Dr. Baiju, I have a question for you. Enjoyed your talk. I appreciate the effort you put in trying to save this very sick group of patients. One, is it true that if you use homograft, it prevents reinfection? Is it a myth? Because he had used homografts and it had got infected again. Had you used just a sort of mechanical valve with maybe a Gore-Tex or a Dacron graft, do you think it would have been better?
No, it doesn't prevent reinfection totally. That's why I was stressing more and more on debridement.
Correct.
But homograft is nice to have. One thing is that it's not as stiff as a prosthetic material. It can go into the cavities. You can manage it, tackle it much more. And you got the attached mitral valve. We can usually use to cover the cavities around. And statistically, of course, homograft has a superiority over any other material for valve replacement in infection. Statistically, it's proven.
The one which root was enlarged and then you have to go back in for infective negative. What material was used for enlarging the root? Was it autologous pericardium, bovine pericardium?
We use bovine pericardium because all were reoperations. Autologous pericardium is not available.
No. The first time when they enlarged the root, what was used?
I'm not sure. It's done by one of my colleagues. If I remember correctly, it's bovine pericardium.
That was area you think got infected, is it?
No, the infection was all around. I think it is a prosthetic valve endocarditis which is extended much beyond. I think the infection should have started in the sewing ring of the valve as usual.
Two patients had just ascending aortic endocarditis in your...
Yeah.
So
that is just like both the MRSA endocarditis, MRSA mediastinitis following surgery, and they were presented with pseudoaneurysm of ascending aorta.
At the cannulation site or the...
One was at the cardioplegia site and one was like all aortas eaten away. The smaller child I told. That were a BDG also, so making our management a little more complex.
Yeah, congratulations, Dr. Baiju. It was excellent.
I have videos on that, but I'll show some.
I'll see it later.
Dr. Baiju, I have a small questions. So when you have a root abscess, so we have done a couple of cases where we don't go for so extensive debridement, just wall off the root abscess with a pericardium, autologous pericardium, and put a valve, maybe mechanical or biological valve, instead of extensive. Do you have any experience on that? And also, I don't think biological valve has more superiority over mechanical valve about endocarditis. I think both has similar incidence of re-endocarditis.
Trying to answer your question, like maybe you have experience, but my thought is that like if an infection to get eradicated, antibiotics should reach. It will not reach dead tissues. So if you wall it off, maybe you are making a sealed off infection, which might remain there as a bomb and then might explode some other. That's just my thought process. So I try to remove as much as possible, leave behind only living tissues with vascularity so that antibiotics can reach there.
But the homograph is a avascular tissue.
Yeah, homograph is a vascular tissue. For some of my belief is that it has higher resistance, and this is the only instance when you had a homograph infection. That is my fault because I left the VSD patch. And after that, I removed the VSD patch 10 years down the line.
Because if you have a VSD patch which is twisting in the first case, would you go in and try to remove it and replace it by inside?
Oh, sorry, Ganesh, I didn't get your question.
Because first time you left a VSD patch.
Yeah. See, I went in with the idea of doing a rose because it was subpulmonic VSD again done by one of my colleagues. It is anchored onto the pulmonary valve. So I wasn't happy. So the plan got changed. Everything was little. I got upset, and then we said, okay, we just salvage the day. Take the valve out and put take the root out and put a homograft. But in hindsight, I realized that that's the biggest mistake I did. That's why I highlighted as the first case for the youngsters, because there is no shortcuts in infected endocarditis.
Sir, doubts? Cannulation strategies, sir? Femorofemoral cannulation or
See, you have to be flexible. When femoral is available, we can do it. What I do in smaller children is that just make the sternotomy incision before going for sternotomy, extend it a little higher up, and you can get the carotid very easily. Carotid innominate easily, and you can also loop the left carotid from the same incision. So if kids less than 10 kg will do that. The bigger boy I showed with the pulsating aneurysm, he was around 15 kg. We had femorals to go. But always keep the neck available. Suppose the femoral is not good. Many times, especially redos, they would have femorals which are cannulated before catheterization done. So even though the Doppler says okay, you can never believe how good the vessel is.
I think in the interest of the time, we can discuss this later. Thank you, Dr. Baiju, for a very nice talk. May I now invite Dr. Shivakumar Shivalingam. He'll talk about aortic valve reconstruction in rheumatic heart disease. I don't think he needs any introduction to this audience. Thank you.
Thank you, Dr. Devashish. And firstly, I would like to thank Dr. Hiramat for giving me the kind invitation. And it's really an eye-opener for me to visit this center, and I hope to make more visits in the near future. Today, my talk is on aortic valve repair in the rheumatic population. So, probably, can I have my slides, please? Yeah, so. Yeah, I see it. Yeah. Yeah. Thank you. I have no disclosures. And I think Dr. Krishna Kumar had talked to you all in length on the prevalence and of rheumatic heart disease, and it's still a problem in an endemic in the developing world. And I think the issues mainly related in aortic valve disease, though the presentation of rheumatics is in the mitral valve, but you have in at least a pure aortic stenosis, post-inflammatory disease can be caused in about 9% of the patients. And pure aortic insufficiency is in 14%. And about 17%, it's more of a mixed aortic insufficiency and stenosis. So there's a very heterogeneous kind of pathology involved, and that makes it a real challenge to repair these valves. And most of the time, these aortic valves, don't present as a single lesion. They come in as a combined lesion with the mitral and the tricuspid valves. Now, if you look at the presentation of the rheumatic population, the presentation is different in the developed nations and the developing nations. The issue that happens in the developing nations is that most of the patients are younger and they come from poor socioeconomic status, and they are non-compliant to medications, and also they come from underserved areas where they don't get access to care. So we need to really prioritize and choose the kind of treatment that we want to adopt based on individual patients rather than thinking of as a holistic approach. Now, the issue that comes with the repairing the aortic valve in the rheumatic is that if you look at the histopathological specimens, you can see that there's a kind of a dense fibrous tissue that kind of forms within the leaflets. And as if you compare it with the normal valve, you can see that there is an extensive line of separation between the normal tissue and the abnormal tissue in the aortic valve, and that kind of brings it as a real challenge. And if you look at some of the stainings that they do on the, they have done on the aortic cusp of a rheumatic patient, the presence of a glycan composition, which is supposed to maintain the suppleness and the mobility of the aortic valve, it kind of diminishes. So in that kind of instance, the repair is going to be a big challenge. If you look at a classic aortic valve in a rheumatic, they can either be very thickened or rolled out, or sometimes they can also be thinned out and they can be a kind of a prolapsing kind of leaflet. So and I think most of the patients that come to you at a later stage, they come in with more thickened kind of leaflets. But if you look at the pediatric population, what we see nowadays is many of them come with pure insufficiency, that is kind of a prolapsing leaflets. And most of the lesions you can see here are kind of a mixed kind of lesion. They have a combined aortic stenosis and a regurgitant lesion. And these kind of lesions are much more difficult to repair. And if you see a view of the aortic valve in a patient with rheumatic, I will go back to the previous slide. You can see that the leaflets are kind of rolled out, and there are elements of fibrosis exist, and also because of the rolled out leaflets, you can also have a prolapse. Now, in these kind of patients, of course, if you don't want to repair the valve, the option is to replace. But especially in the pediatric population in the developing countries, if you put in a bioprosthetic valve, they do not last for long. And if you put in a mechanical valve, then you'll end up with issues with compliance with anticoagulation, and you'll end up with thrombosed valves. The next option is how about the Ross operation? And I think this is the largest series that has come out from All India Institute on the long-term results of the Ross operation in the rheumatic population. But it's shown that the pulmonary autograft is a less than ideal substitute, especially in the young rheumatics because of the high failure rate. Having said and done, but probably in the adult population, where you call them that they are the so-called burnt out rheumatic groups, probably in these patients that you can perform the Ross operation. So there are various techniques of rheumatic aortic valve repair, and I think it all boils down to the pathology and the kind of tissues that you're handling with. If you have a patient with a post-inflammatory rheumatic, they're probably with thickened valves, then you can probably do the technique of peeling or shaving. That is how it was first best described in the mitral valve, and that technique has been adopted for the aortic valve too. And of course, you have stenotic lesions, you probably go in for decalcification and commissurotomy. And now what we tend to see in the pediatric population is incompetent valves, and these valves are not very thickened. And in this kind of instance, they have a lot of prolapse. Then you can consider doing some form of a free edge plication, a subcommissural suture plication, or also probably augmenting the leaflet itself by using various forms of biological materials. Now, just quickly go through this video. I would like to thank Prof. Al-Khoury for sharing this on the rheumatic valve repair. You can see that the valves are thickened and fused, and many a times the calcifications are removed and debrided, and the valves are thinned out, and then you can get a good competent valve. In certain cases, as I mentioned earlier, because of prolapse, you can probably do a plication of the leaflets. Sorry, I can't control the video, so just bear with me for a minute. I know, no, okay, now it's okay. So the next technique is the so-called valve augmentation with the biological materials, and ideally the material that is used is autologous pericardium. And you can use this for either augmenting the leaflets, or in this case, you can probably use a pericardium for closure of a perforation. Right. I think the largest series that we have for rheumatic aortic valve, and the quoted paper is from Dr. Sachin Talwar at All India Institute of Medical Science. They have extensive long-term results on 61 patients with the various kind of techniques they adopted for repairing the aortic valve. And I think from their series, their patients were slightly on the older age group, so they had more of stenotic lesions. So they had used various techniques on the cusps, such as cusp thinning and commissurotomies. And if you look at the freedom from aortic regurgitation at 10 years was about 50%, and excellent survival rates of 95%, with the freedom from reoperation of 85%. And that's been pretty good result in this challenging group of patients. Now, the next technique of repairing the aortic valve, as I mentioned, is a cusp augmentation technique using biological materials. And this has been described for various indications, but it has been widely adopted in the rheumatic patients because we tend to have more of incompetent valves rather than stenotic valves. And this is a series on the long-term results from Professor Kalangos' unit when he was in Geneva. And they had extensively used aortic cusp extension technique, either with a fresh autologous pericardium or photofix. And they've shown good midterm outcomes. And if you look at the freedom from reoperation at 5 years was about 75%. But what they notice is those patients who had glutraldehyde fixed pericardium, such as a bovine pericardium, did much poorly compared to a fresh autologous pericardium or a photofix. And event-free survival was about 68.8% in the midterm. So the problem comes down to, if you want to augment the leaflets, I think there is still no perfect material that is available. And that's one of the reasons why it's always, possible to get a good surgical result, but the long-term results are still questionable because we still don't have an ideal substitute material. Now, we have extended this indication for the rheumatic valve repairs using the aortic valve neocuspidization technique, popularly called the Ozaki operation. Now, the reason for using the Ozaki procedure, from the excellent long-term results from Professor Ozaki himself on a different subset of patients, these are isolated aortic stenosis patients, we try to adopt the same technique on the pediatric population. And the Ozaki operation tends to maintain an excellent effective coaptation height. And the hypothesis is that if you maintain an excellent coaptation height, especially in the growing annulus in the pediatric population, you'll be able to maintain a good durable repair. This is one of our patients in whom we have performed Ozaki repair with a tri-leaflet replacement in a rheumatic patient. And you can see that the leaflets are, holding on very well. And we looked into our results in the rheumatic population of the Ozaki operation compared to our previous results of the conventional aortic valve repairs. So we had about 51 patients whom we performed aortic valve repairs, and 33 patients who had the Ozaki. Of course, most of the patients whom we had aortic valve repairs were in the earlier experience, but since 2016, we are having more of the pediatric population with the rheumatic valves that come to repair, so that we are doing more of the Ozaki operation. And the techniques that we used for aortic valve repair were similar, like cusp thinning, commissurotomy, subcommissural annuloplasty, and cusp augmentation. Most of these patients that came in for the isolated valve repair were more of a stenotic or a mixed kind of lesions. And you look at the freedom from mortality in the was about at 20 years, we had a good long-term follow-up, about 70%. And if you look at the freedom from reoperation, it's been excellent in the first 10 years. But as you go down beyond 10 years to 20 years, I think they tend to start failing. And by 20 years, only about nearly half of the patients needed some form of reoperation. And we looked into the similar results in the Ozaki group because we don't have long-term results in this, but it's more of a midterm outcomes. What we noticed is if you look at the freedom from aortic regurgitation or stenosis, the valves are still functioning quite well. There's not a significant increase in the mean gradient. And similarly, if you look at the regurgitant gradient, most of the patients remain in a trivial aortic regurgitation. And as these patients are in the pediatric population, you can still maintain the coaptation height, though there is a bit of decrease in the coaptation height, but they're still maintaining well with good competent valves. But the only problem that came in our observation was the freedom from any event or reoperation at 5 years was 77%. For some reason, the aortic valve neocuspidization technique compared to the conventional aortic valve repair seems to be performing inferiorly. And one of the reasons that we identified for this was that the patients whom we operated that had acute carditis, they really perform poorly. If you do a cusp augmentation in acute rheumatic carditis, they come back to you for early reintervention. And I think now we have gone away from performing in carditis. We only in non-infective patients, those are the only case that we perform the procedure, and the results have been pretty good since then. Now, if you look at from a perspective of is aortic valve repair really necessary in the rheumatic population with so much of uncertainties in the results? Of course, if you're looking at from a perspective of a developed nation where you have excellent follow-ups for prophylaxis and also management of anticoagulation, a valve replacement can always be considered. But in a developing nation, it's always difficult to perform a procedure and get the patient to come back for medical therapy. So in these kind of instances, I think still the valve repair is helpful, but the important point here is one has to be very mindful of the antibiotic secondary prophylaxis for the rheumatic. And if that is not well optimized, the results are still going to be suboptimal. There's only one systemic review on the aortic valvuloplasty in the rheumatic group. They are combined about 6 series, and one of them is also Sachin's and Professor Kalangos' study included in that. And what they've noticed is that the survival rates have been excellent in all the studies, but the problem comes to reoperation. The reoperation rates are still very high, and one of the reasons for this is they found is due to the primary failure of the repair of patients coming in with endocarditis and also valvuloplasty deterioration. But the key point is in rheumatic is just not an isolated disease. It's also the disease of the mitral valve and the tricuspid valve. So many of these patients come back for reintervention on other valves. So that makes it more challenging to justify performing a valve repair alone and expecting the durability to be in the long term. So in conclusion, the aortic valve repair in young rheumatics is feasible. I think there's no doubt about it. I think with the techniques that are available in the armamentarium, you can perform a repair. But what one needs to be very mindful is you need to apply the specific technique to specific lesions. You cannot generalize it. For example, you cannot say all rheumatics, you have to do only the Ozaki operation. It has to be tailored according to the lesion. The next is in older patients, I think if you have a good size annulus and you can always do a mechanical valve replacement or even a Ross operation can be given for consideration. but the neocuspidization procedures has to be reserved for selective patients, especially in acute rheumatic carditis. I think it's definitely a contraindication to perform a repair. And I think if you do a proper aortic valve repair, one has to be mindful that the antibioprophylaxis is of paramount importance if in case you want to maintain a durable repair in the long term. I would like to thank the organizers for again giving me the opportunity, and I would like to extend my invitation to you all to continue our discussions in November in Kuala Lumpur, where we have the 32nd Annual Congress of Asian Thoracic and Cardiovascular Surgeons of Asia. And I would like to extend my warmest invitation to all in this group and also those who are participating virtually. Thank you.
Excellent talk, Dr. Shiva. What are your thoughts on using sort of not non-standard templates to do Ozaki? Because there are places where they would not have access to the template for making the cusps, and they would still go ahead and do it. Do you have any thoughts on that?
Well, as what we know, the technique of neocuspidization using the Ozaki is not new. And I think this technique has been described by various surgeons like Carlos Duran, in his experience many years ago. But I think if there is a surgeon is able to really judge and make a proper measurements and do it, I suppose, I don't think so there is a problem with that. But the Ozaki procedure, the templates are so foolproof. All you need to do is just follow the measurements, and you get excellent results. So I certainly think that if you want to have your results consistent, it's always good to have those templates. Yeah.
Dr. Shiva, I enjoyed your talk. Now that the 5-year results of Ozaki is inferior to the usual repair techniques, what modification do you think, having the knowledge of both Ozaki and the previous valve repair, what do you think, when would you do an Ozaki and when would you try to preserve the leaflets and try to repair?
Excellent question. I think if you have a patient in the pediatric population, young patients, if you have you need to assess the valves. If they are just a single leaflet that is involved, I think it's not wise to go and replace all the leaflets. What I would do is just go hard and try to repair that particular single leaflet with some kind of a cusp augmentation technique. And then probably, I think that would probably be enough to give you a durable result. And that's what has been done in the past. Furthermore, if you have stenotic lesions, like where you can just get away by performing a commissurotomy or a cusp thinning procedure, I think we should still aim for that. And then we can probably try to, get a good, effective result by performing that. I think if you have all 3 leaflets that are destroyed and you have a regurgitant lesion rather than a stenotic lesion, I think that's going to be a tough case for you to go and repair. I think in this case, and especially the pediatric population, you want to change the valve, but you have a small annulus. I think it's also going to be a challenge trying to enlarge the root and put up a prosthetic valve. These are the cases where I think I'll definitely do the 3 leaflet Ozaki. And I'm very mindful of this because I know from the results that have been for all techniques using substitute material. I think there is no good substitute material that is available until date. So I'm very mindful that the patient is going to come back. I'm not going to tell the family that I've done this surgery, your child is not going to come back to me. No. What I usually counsel them is we are going to do this procedure because this is better than placing a valve. We'll allow your child to grow, or probably it's a lady, hopefully can complete the family. And definitely there will be a time where we need to re-intervene. And at that time, I would certainly advise them to have a prosthetic valve.
So the problem which we face is that you know that these children are going to come back. But when you have planned an Ozaki, you have to remove extensive piece of pericardium to prepare it.
That's no problem at all.
So 20 minutes of clamp time, if you lose, should not be a problem.
No problem at all. I think, but what fear many have is you're taking out a huge piece of pericardium, you're leaving the whole chest, whole heart behind the sternum. So far, we had no issues at all when we went in for the redo operation.
Experience with bicuspidization, because it's theoretically simpler. You just have to make two valves sort of length equal. So what is your experience with
Yes, bicuspidization, I still do it for, if you have a unicuspid valve or a bicuspid valve with unequal size leaflets, I still do the bicuspidization. And before embarking on a Ross operation, I think it's still better to repair those valves. But in rheumatic, I think the bicuspidization, the anatomy does not suit for you to do a bicuspidization repair, because in the natural way, it is 3 natural leaflets are there. Performing a bicuspidization will be a challenge. That's my opinion. Yeah.
One of the things that we noted was when we started doing Ozaki from 2016, it was very well nice and you got a good this thing without augmenting the routine small kids. But later on, as the children grow, we actually found that the gradient descending, and we had to go back in only for stenosis with a valve which was descending. So now actually, if we are going in for those children, we are widening the route. Paradoxically, that gives it seems to be giving us a better long-term freedom than initial results will be excellent, but when they get that teenage growth spurt, we found that when they start growing up, it became relatively stenotic. With the road wide.
Another thing, an extension to what Professor Shima mentioned is, I think if you look at the new templates of the Ozaki, you can see that the coaptation height is going to be down, because the problem is the old templates show that your coaptation is almost at the level of the commissures, but the new templates are bringing the coaptation level down almost to what it is going to be in a natural position of an aortic valve. So I think one of the reasons is, we kind of think that if you have a long coaptation zone, it is very good. But I think that long coaptation zone may not be good, because that will leave some kind of a gradient across, and that will probably, make the leaflets less durable. This is what my thought is.
We found a 15 hertz oscillation of the leaflet when the depth of coaptation was more than 10 millimeters.
I just want to comment nothing against this, but I don't want the audience to believe that Ozaki is bad, because you exactly said in the people who are on active carditis. I have around 47 patients. We started doing for the last 4 or 5 years. Only one death delayed death at home. Don't know the exact reason. The remaining patients are doing well. Okay, I think here we have to keep the patient, but this pericardium is not going to last for long. As Dr. Shiva rightly said, you shouldn't be performing in acute carditis.
So that depends. How do you define acute carditis? CRP levels, CSR, what do you go?
I think what we do is, there's especially some of the patients, acute carditis, they come in with 2 valve problems, the mitral and the aortic valve. In those kind of patients, I will be a bit careful to do the Ozaki operation. And especially when you open up, you have a pancarditis kind of a picture. They have very thickened pericardium. And these are cases that will not be good cases. And I would like to thank Dr. Vijay Kumar. He's been a huge proponent of the AV Neo in India. And I think as what I would just want to echo what he says is that, you choose your patients carefully. I think there is no one particular procedure that is, that will fit all patients. You need to choose the lesion, choose the patient, and choose the procedure. And that's what is the key here. Yeah.
Hello, Miss Shiva. Nice presentation. Nice to see my mentor after a long time. 2 questions. One is, you mentioned the freedom from re-intervention, 77%. So what are the reasons, whether it is the failure of Ozaki or it is the disease progression itself?
Thank you. As I mentioned, the patients that we had the re-operations were all failure. This is due to acute carditis. They basically the valves got thickened. And in those patients, we didn't have native pericardium because they were thickened valves, leaflets. So we went and put in a decellularized pericardium. So that's one of the reasons they failed. Number two, acute endocarditis post-procedure, because I think the endocarditis rate is still high post-Ozaki operation. And I think this is where I clearly mentioned about the antibiotic prophylaxis that is of paramount importance.
And you showed a picture depicting clearly geometric height, effective height. So I want to know whether do you consider these things in deciding whether you should go for a Ozaki or a repair of the wall, or you just go on the morphology of the leaflets?
I think I go by the morphology.
Morphology. Yeah.
Thank you.
As he said, it is the lesion. All three leaflets are retracted. So definitely we have to be high.
Agree. Yes. Agree.
I think that area was like still serves better than that. Where replacement in young people.
Yes, I would like to make a comment. Excellent presentation. Congratulations. You know what I'm doing also, because we have also to mention that there is another alternative surgical option is to do aortic annular enlargement conotype, because you have to implant a bigger prosthesis. This one is a good option because it's like a definitive surgery. You are able even to go and implant 23 mechanical prostheses, especially, you know, when I had some female patients coming from Africa with aortic stenotic lesions, where, you know, as you mentioned properly, you know, you cannot expect to do a good aortic valve repair with catheter extension. I was doing the aortic annulus, the cono with homograph, aortic homograph root implantation. And I was able, you know, to implant 19, even 21 aortic homographs. The advantage of this one with the new TAVI technology is like, you know, you can go and repeat it later on. This one also opens, this surgical option opens new horizons.
So replaced with a bioprosthetic.
Yeah. I had, you know, a lot of cases, and I can tell all the aortic homograft I implanted in female patients, you know, during the childhood. I had during, you know, the post-operative 10 years, I had, you know, very few surgeries, reoperations. And now, you know, with this new technology of TAVI, because female patient coming from Africa, to condemn, you know, this female patients not to have children is a big handicap, social handicap in Africa. And for that reason, you know, I was preferring in the subset of patients to implant homographs. And I have the impression now, you know, the debate will be over the coming next years. What is the best, homographs versus Ozaki? As you mentioned again, the problem, I have a problem because I was, you know, a fan of pericardium, phage pericardium, glutaraldehyde pericardium coming out from the Carpentier school. Again, you know, I have very strong doubts regarding the behavior of this biological material in midterm and long term. And for that reason, homograph can be a good option because you enlarge the annulus, you will be able, you know, in a 19 or 21 aortic homograph to implant endlessly TAVI.
Prof, since you mentioned about TAVI, now it's also evident that if you do the Ozaki, you can do the TAVI now. So that's still an option there.
It's a top option.
Thank you, Professor Kalangos and Shivakumar. I'm sorry, in the interest of time, as well as we have to coordinate with internet presentations too. Dr. Christopher Baird is waiting for continuing the discussion. Can we have Dr. Christopher Baird come in, and please?
Hello, can you hear me?
Yes, Dr. Baird, we can hear you well.
Ah, okay.
Christopher, welcome once again and kindly go ahead with the presentation, sir, please.
Yeah, I'm just trying to share it now. Can you see the slide? Can you see the slide now?
No, sir.
Can you see the slide, guys?
Yeah, we cannot see the slides.
We can't see the slides. Are you sharing the presentation?
I was. Let me try again.
Are you able to share or?
I'm trying to share now.
Okay.
Okay. What about now?
Yeah, that's right. We can now see the slides. You can go to full screen. Yep.
Is it? How's that?
No, it's okay. I think if you're happy with this, we can take the presentation with this.
I can try to switch the screens.
You have to go to the presentation.
Yeah, it's on my other screen. How's that?
Yep, that's right. Good to go.
Okay. All right. I'd like to thank the society and the organizers for inviting me to have a discussion today on what I've really called current trends in aortic valve repair, and really it's not all about the leaflets. And this will be a focus not so much on the rheumatics per se, although you can use some of these techniques in rheumatic patients, but other types of aortic valve disease. No disclosures. Options for aortic and truncal valve repair in infants and children and teenagers are somewhat limited, although now we have other options that we haven't had in the prior decade. Preoperative imaging is critical, and I'll show you some examples of the newest imaging techniques we're utilizing to understand aortic valve anatomy. The durability of the Ross operation in several settings is in question. In repair using native tissue has clearly been the most effective. I'm not here to tell you that I necessarily have a better surgical technique, but to show you the way we are now thinking about aortic valve reconstruction and to highlight really a couple of new concepts and tools that we're using, but to emphasize that aortic valve reconstruction, again, is not all about the leaflets, but it's really about the whole aortic valve complex. So what are the components of the aortic valve complex that need to be considered? It's the subvalvular apparatus, the annulus, importantly, the leaflets, the sinus and sinotubular junction are quite critical, as well as the ascending aorta. So in terms of leaflet repair techniques, these are some of the historical techniques you'll see here in terms of types of prolapse repair, leaflet extensions, commissurotomies, sewing leaflets together. And then we've had newer techniques, which aren't so much repair techniques, but replacement techniques, such as the Ozaki, that has been discussed extensively already at this meeting, including 3-in-1 leaflet or single leaflet replacement techniques. as well as bicuspidization techniques. And this is a technique that I'm going to focus on here and give some considerations on using this type of technique in order to utilize as much of the native tissue as we can, restricting the reconstruction to the commissure. Assuming that if failure occurs, it will occur in the commissure and the rest of the valve might continue to function well. First, you have to think about the annulus. And if you look back to the David 3 operation, that incorporated a strip, as you'll see in this image, of annular support. And this was basically a piece of the graft that was wrapped around the annulus in order to not allow the annulus to dilate. Subsequently, Lancet came up with the Lancet ring to support the annulus, then the corneo, and then Rankin has come up with his ring, and Schaefer's has popularized his technique with Gore-Tex as one we favor in many situations. So we think it's important as we're thinking about reconstruction to be able to support the annulus. Now, the sinus and the sinotubular junction are critical components, whether it's enlarging the sinus or narrowing the sinus down. It can have critical implication on what happens to the leaflet. You'll see in this image, if the intercommissural distance is too short, the leaflet can buckle on you and you can have these areas of regurgitation. Yet if it's too long, it stretches out the leaflet and you'll have a broad area of communication. Incidentally, this is an image I created for the Ozaki reconstruction. And this is a really critical point when you're thinking about doing the Ozaki in young patients, small patients, when you're doing annular and root enlargements and things of the sort. We can also deal with the sinuses and sinotubular junction by replacing them and doing essentially a valve sparing type repair. And we do that for many types of conotruncal aortic valve disease where the conotruncus is abnormal, and especially the sinus and the root, such as after arterial switch operation. So considering aortic valve repair and reconstruction options, you clearly have leaflet options, including patch augmentation, resection, plication, resuspension, bicuspidization, leaflet replacement. In terms of the root or sinus for reconstruction, you can augment, you can resect, plicate, you can do valve sparing root replacement, or even suture annuloplasties. And in the annulus and subannulus, you can do enlargements, plications, and again, suture annuloplasty type repairs. So you can use all of these techniques when considering how to repair or reconstruct the valve. But really the goal is to maintain as much normal native tissue as possible. So to help do that, we need some tools. And this is a schematic drawing of the aortic valve. And importantly, to think about the geometric and effective heights as Schaefer's has popularized. He created a caliper, and it's an important caliper, especially when you're beginning these types of repairs, to really gauge the appropriate effective height and leaflet height or geometric heights. Now, to talk about image guidance, we've now began to utilize Cine-CT and modeling techniques to help us understand exactly the aortic valve anatomy in many of these patients. And you can really see in some of these images, and as we utilize the images, we can make measurements in the patients to help guide us on the exact dimensions that we should be accounting for the free edge lengths of the leaflets. This allows us to reconstruct the leaflet free edge lengths to appropriate lengths for the corresponding sinotubular junction diameter. And we can utilize the Mimics viewer here in order to enlarge and break down the aortic valve complex to allow us to look at it. You can see the relationship, the external coronaries and the ostium in the coronaries and things as such. This you can begin to see. We can also look at the LV outflow tract from the external view. This is a patient who had significant aortic valve disease as well as severe left ventricular outflow tract obstruction, but it gives us an idea of how we can start to plan to reconstruct not only the aortic valve, but the LV outflow tract in this case. And this is just another example And yet here's even another example. It's a very nice picture of a unicuspid valve. It gives the height of the commissures. And you can see the low set nature. It shows you the coronary artery there, the anterior right coronary, the left coronary. It gives you an idea of how to plan your reconstruction in and around the coronary ostium, let's say, of where you're going to bring the height of that commissure up to. You can also make measurements in this algorithm, and we can measure the free edge lengths and get an idea of how long that free edge length is going to be and the corresponding nature of it for the diameter of the sinotubular junction, and how much we need to elongate that free edge length to allow the valve to open completely. Now, this is just another example of some newer imaging software that you can take echo images and get these amazing three-dimensional views to help guide the repair process in much the same way we're using the CT. So we'll take a couple of cases and just give some examples. This is a typical patient of a 14-year-old with a unicuspid or bicuspid, frequently called valve and echocardiogram, got neonatal aortic balloon valvuloplasty, and now had severe mixed aortic valve disease. So in this case, the annulus is normal. Two of the three leaflets are basically normal. He's kind of absent a leaflet. You'll see the three-dimensional view here. It gives a nice picture. The right coronary, very deficient anterior leaflet. This is the area of malcoaptation. This is where the regurgitation is. This will be the non-coronary leaflet. This is the left coronary leaflet, which are actually well-formed and good. This patient had an ACE in the aorta that dilated as well. So when we're beginning to think about this valve, we have to think about the geometric and effective heights. So we can use the caliper to do that. And then, but one may say, well, how does that help us? You can actually look, and there's tables out there now, and this is in pediatric patients, based on the body surface area. These are the predicted dimensions according to body surface area for the effective and geometric heights and what they should be. And as you'll see, in general, the effective height is the effective height is 1/2 of the geometric height. So part of the goal of the operation is to use as much native tissue as possible and to achieve an effective height appropriate, because Schaefer's published this in the adult patients is clearly if you achieved an effective height greater than 9 millimeters postoperatively, these patients did far better. So what is bicuspidization, the unicuspid valve? This was kind of Schaefer's first modification of it, which was great. In a single surgeon's hands, it can be done once experience is gained. But I suggest that from the preoperative images, we can figure out what the free edge length should be and what the target leaflet height should be. And based on that, we can make this operation more routine and consistent for other providers. So this is a really important image to think about and look at. And this gives you the bicuspid valve and cross section. And we often see this kind of oval nature of it. And really the reason that is because the length of the free edge here is too short for the diameter. So the problem is that if you see in the side view here, these leaflets go very high. And if you go to the other extreme, this leaflet goes down and has a very low coaptation height, whereas this valve has a very high coaptation height, much like the Ozaki and the older templates. If you go to this extreme, you have very little coaptation height, and then you tend to get prolapse. So really what you want to shoot for is this type of free edge length of the leaflet to give you an optimal opening of the valve. And we've created charts in order to get that. And basically, you can get to this effective height to get this optimized orifice area on each patient. So in other words, we're shooting for this, about 80% opening. This is just a simplified table that based on the diameter of the sinotubular junction tells you the exact free edge length you should have in order to create an effective functioning bicuspid valve in appropriate height. So how do you do the procedure? This is a typical unicuspid valve, and sometimes this is even more deficient. You can go in and you can resect all or parts of this. And once you've resected that, you go in and replace that side of the commissure area over to a portion of the valve with what was typically used was autologous pericardium. And I'm going to show you some examples now. We've gone into the next phase of this where we're using the aortic wall to replace this segment. So now you have all native living tissue, including the aortic wall, is a part of this here for the reconstruction. So we think that's going to be better. We have about 19 patients. I did one yesterday to make 20 actually, using the aortic wall. And this is just an example of how we often support that repair with the Gore-Tex annuloplasty as described by Schaefer. So I'll give you just a quick video example of bicuspidization of the aortic valve. And you'll see this is a typical unicuspid valve. And I'll try to move through these videos. I'm coming up on 15 minutes. I had several several short clips to show you of some examples. So I'm going to move through these a little bit quickly. But you can see here we're resecting the anterior segment or thinning out some of the thickened portion of the valve here. And then once we get that segment out, we try to keep as much native tissue as possible, but we end up resecting a fair bit of the tissue. And then you'll see we're going to basically fill that space in with a pericardial patch. Now, this patient required a fairly good size of pericardium to create or fill that anterior space there. I'm just going to scoot through this, and you'll see that I'm trimming this down, trimming the free edge length off to replace just that portion of the valve. And now you have a valve that fully opens. And now we're going to complete the annuloplasty going under the coronary arteries. And then we're sizing it with a hair, we're tying it, and you have a functional bicuspid valve with very little regurgitation. So again, we were shooting for the free edge length to equal this in order to have an effective coaptation height where we don't get prolapse. This is another example. Similar patient. You can see the anterior area is restricted. We're going to go in and resect a portion of the valve tissue here. That string there is my mark of how long the free edge length should be for the valve. And again, we're resecting. We're going to replace portion. This valve also requires a fairly decent size piece of pericardium for the reconstruction. I'm just unroofing the coronary artery there. It also had an intramural coronary. And then we're going to go in and we're going to put the annuloplasty under the left main coronary. You have to take care and not damage the circumflex coronary artery. We're going to size it up. Now, as I mentioned to you before, you have to keep an eye on the sinus because you don't want it too big or too little. So here we resected some of the sinus in order to narrow that down to an appropriate size. And you can see we did an ascending aortoplasty there and took that piece of aorta to narrow it down. And we come up with a fully functioning, effective bicuspid valve. And now a similar operation, except we're going to use the aortic tissue as the patch. You'll see we're lining up the valve, we're debriding it. And once we debride it, we're going to come in and we're going to use essentially aortic wall. This is the prior one. This is the aortic wall. Again, with the breeding it, you can see we've taken a piece of aortic wall. And then we're going to trim that. We're going to mark it. And it's a little bit thicker. As you'll see, but it turns out frequently these aortic valves are a little thicker anyway, so it's not too bad a mishmash. Sorry, it keeps jumping back to the other one. And here is the completion after using the aortic wall. We're closing up the non-coronary sinus, and then we're going to put the aorta back together. And that's completed. So patient 2, this is a 16-year-old with a tricuspid aortic valve, a history of subaortic stenosis, subaortic membranes, had several subaortic membrane resections, has had prior aortic valve repairs, has moderate to severe AR, severe AS, has an annulus of 20 millimeters, which is a Z-score of 0, but an STJ of -4, and has a sinus of -2. So we have all kinds of difficulties here to deal with if we're thinking about reconstruction. But if we think about all the other concepts at each level of the aortic valve, we can start to think about how we can reconstruct it here. We first start with our three-dimensional image that gives us an idea of how that valve necks down at the sinotubular junction. And we'll also get an idea of the subvalvular narrowing or the relationship with the coronary arteries in terms of the commissures. And now we've got the aorta open, and we're measuring the height of the leaflets to get the geometric heights, and we're taking out the coronary now because we realize that a technique that might be useful here is the valve sparing idea in terms of replacing the sinuses with a graft. So once we open up the valve, now we're going to take down the commissure raphe, if you will, and we're going to start to think about how we can bring this valve together, minimizing use of external materials to reconstruct the leaflet. So we're mobilizing the leaflet here, and it's very, very thick, but we're able to thin that down, mobilize it. These are some of the old repair sutures you can see that we tried to pull the leaflet up, that were taken down. And then we'll continue mobilizing the leaflet, thinning the leaflet out, pulling the extra gelatinous material off of the leaflet. And we're taking a look at the height, and we're realizing we don't have enough height on the valve, so we need to figure out how to get more height on the valve. So we thin it out, and now we're going to start plicating that leaflet to raise the height on it, much like you would do for a prolapse repair. And you can now start to see the valve has come together a little bit in terms of height. We're going to split the commissure a bit on both sides to get as much orifice as possible. And we're placing our sutures below the annulus for our graft to support the sinuses. Now that we've gotten the valve thinned out and essentially bicuspidized, and we're essentially going to do a valve sparing technique here, utilizing the graft to sew in this annulus. And then we can test the valve by putting cardioplegia in there, and clearly it's maintaining its competence. That's before we put the coronary buttons in. We put the coronary buttons in, and we can complete the operation, you can see that we have a relatively good functioning bicuspidized valve with all native tissue in this patient. And then the final case, you can apply these concepts. This is a neonate with truncus arteriosus, severe truncal valve regurgitation, coarctation, or hypoplasia of VSD. And part of my reason to show this brief case is to show you a lot of the techniques that we've been talking about and how it's important to consider all the valvar, subvalvar, supravalvar areas in the repair. So we assess on echo. We open up the aorta and we see this neonatal truncal valve. It's got basically 4 leaflets. And now we have to figure out how to get adequate coarctation. That's the right coronary up at 2 o'clock. We're going to take down essentially one of the commissures or raphe between 2 of the residual leaflets in order to allow us to sew those leaflets together. And when we're doing that, we're going to reduce the sinus. And to reduce the sinus, we're going to take the coronary out in order to allow us to do that reduction into the sinotubular junction. And ultimately, we'll sew that back in as a button, much like we do in an arterial switch. Now we're switching over and we're making our ventriculotomy for the VSD repair. We're going to do the VSD repair because that's where our conduit's ultimately going to go through the ventriculotomy. And then we're going to go back to the leaflets and we're going to put those leaflets together to try and approximate them in order to give us essentially a 3-leaflet valve. Now we're going to put the coronary button back in after we've narrowed the sinotubular junction down for the effective or appropriate geometric height and effective heights for that size sinotubular junction. And then once we now effectively reduce the sinus, we have 3 leaflets. And you can see that that anterior right leaflet needs plicated a bit. So we're going to plicate that. Here you can see that it's prolapsing a bit on us. So we're going to fix that prolapse. Now, we know what the leaflet free edges should be, at least theoretically, because we've done the calculations ahead of time. So it gives us some guidance for that type of repair. Now you can see the leaflet starting to really come together and hold. And now this is a subannular plication. We found this to be a very effective, important tool in truncal patients. And I've just now started doing it in neonatal truncal patients to support the annulus. This is a repair technique that we utilized in older truncal patients when they came back. We figured, why not just do it from the beginning? It gives the coronary truncus something to sit on right there where that VSD is. So this is just the arch reconstruction because it was an interrupted arch. And you can see the postoperative echocardiogram. We have a well-functioning 3-leaflet truncal valve with not a lot of regurgitation. Now, so what are the next steps? It's really to track these cases, to look at our calculation predictions, to see how well they informed us, and to explore the use of 3D echo for these measurements instead of CT scan, and continue to develop simulation methods. This is an app on your phone you can utilize to really look at and guesstimate the free edge length. And it gives you ideas on how the free edge lengths and what they should be in order to complete the repair. So in summary, simple measurements and calculations for predicting normal valve proportions are useful to determine leaflet free edge lengths given a certain sinotubular junction. The outcomes are promising, but clearly we need more rigorous assessment. So a quantitative approach might also provide some insight into suture annuloplasty sizing. And in conclusion about bicuspidization, it can be extended beyond the population of bicuspid patients, and bicuspidization is a viable alternative to the Ross procedure, homograph implantation, and neocuspidization for patients with congenital aortic and or truncal valve disease. Thank you.
Thank you, Christopher. I think we can take just one question. We are running short of time, sir. Any questions are there? Chairperson can decide.
Hello, Dr. Bate.
Yeah.
Hi, thanks for coming in. I know it must be 3:30 a.m. at Boston, right?
Yeah.
Yes. Sir, I have one question for you. How these kids are doing after the annuloplasty, especially when they grow. You're putting a Gotek sutures around the annulus. when they come back to you after 3 years or 4 years, how do their sutures hold? Or what happened to the annulus?
Yeah. So what we've seen is I don't put it in small children. And usually I try to avoid putting suture annuloplasties in anything less than around 16. But what we see is those suture annuloplasties do relax a little bit over time, at least with the Gore-Tex. So we haven't had any patients we've had stenosis from an annuloplasty that we've had to go back on. But we're careful not to do it in the smallest patients. But if that was the only issue in the future that we had to go back for a division of an annuloplasty suture and a subannular enlargement, it's a leaflet screw, that might not be a bad alternative depending on what your other alternatives are. But we haven't really seen that as a problem to date.
Okay. Thank you, sir. I do have one more question. How will you do your bicuspidization when you have a coronary sitting at the top of the commissure where you want to recreate with a...
Yeah. So what you have to do is you just have to shift it just off. The patient I did yesterday, I was almost sewing into the orifice of the left main coronary, but you can shift it off just to the right or left of that. So, and then what you can do is you can actually resect one of the sinuses to equalize the sinuses again. So you have still a pretty much 180 degree, but it's okay to go off one side of the coronary or the other a little bit, even if it's not directly 180 degrees from one another.
Okay. Thank you, sir.
Thank you.
I think, Danny, we can move with the next session, please. Next talk.
Okay, so the next speaker is Dr. Zohair Wael Halis. He will be talking on Ross procedure in pediatric patients, case selection, technical aspects, and surgical outcomes. He is there with us online.
Everybody, I thank you for the invitation, and it's a great pleasure to be participating in this important symposium. I will be discussing aortic valve disease in the young and what surgical options do we have.
You've got the wrong slides up.
Aortic valve disease in the young may be acquired, and in the acquired we have rheumatic heart disease, infective endocarditis, aortic valve disease associated with...
Sir, 1 minute. This is a different video. 1 minute. Please check it out. Go release. Yeah, this one. Put this. Yes, boss. Yeah, our apologies for the wrong slides. Yeah, you can go ahead, please.
Good evening, everybody. I thank you for the invitation, and it's a great pleasure to be participating in this important symposium. I will be discussing aortic valve disease in the young and what surgical options do we have. Aortic valve disease in the young may be either congenital or acquired, and in the acquired we have rheumatic heart disease, infective endocarditis, or aortic valve disease associated with connective tissue disorders like the Marfan syndrome and others. Surgery for congenital aortic valve disease can be a major technical challenge because these are generally small children. They may have a small annulus. There could be left ventricular outflow tract crowding causing some obstruction. And there might be also other concomitant cardiac anomalies. Valve repair is generally the treatment of choice in the young if feasible. However, any type of reconstructive surgery is in a way palliative, as more often than not, a redo surgery will be required. We know, however, that a prior aortic valve repair does not preclude all other options. When we deal with aortic valve disease in the young, we have to really produce what is a competent, not stenotic aortic valve with minimal gradient at rest and during exercise. And this is very important during exercise. We have to remove any left ventricular outflow tract obstruction if it exists, and this may require annular enlargement. And hopefully, this will lead to left ventricular hypertrophy regression, improved LV function, and improved survival with good life quality. One has to remember that aortic valve disease diagnosed in neonates and infants is considered a lifelong condition requiring repetitive interventions. So therefore, treatment strategies should aim to allow the largest proportion of patients to have the least number of interventions over their lifetime. Balloon dilatation is known as an effective way of dealing with aortic valve stenosis in the young. However, recurrence after dilatation can occur and is up to about 80% in patients less than 3 months of age. However, redilatation is feasible. Percutaneous balloon valvotomy usually causes rupture along lines of at least lines of least resistance, either along the underdeveloped commissure or into the leaflet itself. When this happened, hopefully that does not cause an acute emergency. However, repair of these surgically is feasible. We believe that we believe that surgical aortic valvotomy is probably a better option because it allows direct inspection of the valve. It allows more fashioning of the commissures and debridement of any excess tissue or nodules that exist on the leaflet. It also gives us the chance to further repair the valve. We may make a bicuspid valve tri-leaflet, use cusp extension, and as you see in the right top corner, occasionally in some patients where I harvested a sinus with a leaflet from a homograft and used it for replacement one of the leaflets of the valve. The question of balloon valvotomy versus surgical valvotomy is always there, and there is no doubt that the disease has been primarily treated by interventional cardiologists due to less invasiveness and because the cardiologists in most centers are the gatekeepers. And only few centers would treat the disease by primary surgery. And hence it is likely that most surgical teams have unfortunately have little experience. Just looking at the strategy of dealing in general, of dealing with the aortic valve, as we mentioned before, we have the repair option. Also, we have the catheter-based option. But then if these don't work out, then we have to go to the replacement option where we can utilize mechanical valves or go the biological route where we can use the standard stented valves or the stentless valves. And in the stentless, we have the options of using xenografts, sonografts, or the autografts, or what we know as the Ross procedure. If you look at the tissue valves, these are unavailable in sizes smaller than 19, maybe a 17 size is coming up. Unfortunately, they have tendency to degenerate, and the younger the patient, the faster the degeneration. Homografts are another good option. They produce excellent hemodynamics. Availability in small sizes is unfortunately limited. They do not require anticoagulation. However, similar to tissue valves, they ultimately degenerate, and the younger the patient, the faster the degeneration, which can even be accelerated. As you can see here, this is one patient, 6 months of age, that we used the homograft on, and the homograft actually degenerated and calcified in less than 6 months in that particular patient. We still believe that the biological option has a role in children, and this is a publication that we looked at our institution using the biological valves in children. And our conclusions were that while valve reoperation is inevitable following AVR and MVR with biologic and bioprosthetic substitutes, favorable results such as low valve-related morbidity, good long-term survival and functional status encourage their consideration as valid replacement alternative in selected children, especially females. And this is a competing risk analysis curve where you can see in these patients there is an ongoing attrition with mortality, but this is very, very minimal. However, the reintervention rate as time goes by increases, and the number of patients who are alive alive and free from reintervention, it dwindles down with time. And in this particular series, by about 15, 16 years, almost all of the patients required another reintervention. Looking at the mechanical valves, despite the many disadvantages, it remains a choice. We know that they can form a panis that can be obstructive and require reoperation. They require need for anticoagulation with its drawbacks, especially in the young and in particular females who wish to become pregnant. Despite anticoagulation, there is possibility of thromboembolic complications, and also with growth of the patient valve prosthesis, patient mismatch can develop, and hence there is always a need for replacement. Mechanical valves are not available in small sizes for infants and children. The smallest available size is 15 millimeter, available from St. Jude Medical. Small prostheses have inferior hemodynamics. They also require for anticoagulation with its well-known limitations, particularly in children. And everybody knows that control of anticoagulation can be very difficult in the adults and in children and in most parts of the world. If you want to consider what an ideal valve substitute should be, it should be silent, non-thrombogenic, producing normal hemodynamics. It should be readily available, has the potential for growth, infection resistance, easy to implant, and durable. And unfortunately, we still don't have such an ideal substitute, but we believe that the Ross procedure or the utilization of the patient's own pulmonary valve to replace the aortic valve is the closest to the ideal. We embarked on using the Ross procedure early in the 1990s, and we were very encouraged with the procedure initially, and we offered it to almost any young patient with aortic valve disease, including rheumatics. When we looked at our results at 10 years, it was obvious that a significant number of patients required reoperation, and most failures we found were in rheumatic patients. We concluded that the risk of autograft failure increases in the presence of rheumatic mitral valve disease requiring surgery. And this is just a picture of such a valve where actually the histopathology demonstrates the ash of bodies typical of rheumatic valvulitis. And we published this as a caveat for the procedure early on. We found that the highest risk group for autograft failure are those with rheumatic aortic valve regurgitation and with dilated aortic annulus. We looked something at 27 millimeters, indexed 16 millimeters per body surface area. We also have associated rheumatic severe mitral valve regurgitation. We therefore did some modification in our techniques, not to use the pulmonary autografted. There is pulmonary regurgitation, not to use a bicuspid pulmonary valve. We leave very little RV muscle below the autograft, and we suture the autograft right very close to the rim of the valve leaflet. We also transfer both coronaries as free buttons, and we try and preserve the non-coronary sinus as much as possible. And we harvest the pulmonary autograft short. We also avoid Ross procedure in the presence of active rheumatic process, if there is concomitant severe rheumatic mitral valve regurgitation, and if the aortic root is dilated, particularly if there is pure aortic valve regurgitation. We sometimes, in gray zone or in borderline patients, we use root reinforcement and also sinotubular junction reinforcement. And in rheumatic patients, we continue penicillin prophylaxis for life. And it's very important to control the blood pressure and avoid hypertension, particularly in the first 6 months post-operatively. We also noticed that patients who have congenital heart disease do much better than those with rheumatic aortic valve disease. And therefore, this was a publication early on. Again, we felt that the Ross procedure is more suited for patients with congenital aortic valve disease, particularly like very young children and maybe infants and neonates. And that particular interest was reinforced by another publication later on, which also proved to us the superiority of the Ross procedure in patients with congenital aortic valve disease. And if you look here at this graph, you find that the indications for the use of the Ross procedure in our institution kind of shifted from patients with rheumatic aortic valve disease to patients with congenital aortic valve disease. We also looked at the mechanical valves versus Ross procedure for aortic valve replacement in children, propensity-adjusted comparison for long-term outcomes. And for this demonstrated to us that the Ross procedure confers a survival advantage over mechanical valves, as you can see in this graph, where the Ross patients have stable survival, while those with the mechanical valves continue to have continuous attrition, and this is more obvious in very young children, where a mechanical valve is used, where actually attrition rate is significant compared to the Ross procedure. We also noted in our series that patients' hemodynamic manifestation is important factor, as patients presenting with stenosis or mixed stenosis and regurgitation, with the stenosis being the predominant hemodynamic lesion, do better than those with pure aortic valve regurgitation. The beauty of the procedure also is in this pathology, where actually there is an association of left ventricular outflow tract obstruction, valve stenosis, and even maybe involvement of supravalvular area. And we kind of modified the general technique rather than being radical and creating a VSD like a cone kind of enlargement of the outflow tract. We believe that minimal enlargement of the outflow tract by generous myomectomy is sufficient. We also can sacrifice the aortic valve annulus and match the annulus only to the size of the pulmonary valve of the patient, which often is not that big. And we feel that this would be enough and actually simplifies the procedure, because you don't have to create a ventricular septal defect. And the outcome from this modification was very excellent. Again, another publication looking at the fate of the neo-aortic valve and root after the modified Roscono procedure, or what I call the mini Roscono procedure. We looked at the annular growth, and it was within the normal Z score. We looked at again the Z score itself, which was again within normal limits. We looked at the annular growth in various age groups, 3 years, 3 to 10, and more than 10 years, and again it was within the range. We looked at the annular growth if there is a concomitant surgery or no concomitant surgery, and again the growth was within normal range. We also looked at the size of the root and the root growth, and again whether in millimeters or Z scores, they were all within normal limits. We looked also at the various age groups, 3 years, 3 to 10 years, and more than 10 years. And again, the root growth was within normal limits. We looked at the regurgitation. Again, there is minimal progression of regurgitation. It's always less than mild. However, older patients tended to have a little bit more increase in aortic valve ratio, but not to a significant range. So our findings from that publication, that there is evidence of autograft growth. The annulus is stable, and root scores growth isn't out of proportion to somatic growth of the patient. There is rare autograft regurgitation, which is usually trivial and non-progressive. There is no autograft reoperations within our follow-up intervals, and some of the patients at this time have more than 15 years of follow-up. So these results support the utilization of the modified or the mini Roscono as the procedure of choice in children with complex left ventricular outflow tract obstruction associated with aortic valve stenosis. So if you want to look at the ideal valve and compare the Ross procedure to the ideal valve, the Ross the autograft is silent, it's non-thrombogenic, produces hemodynamics even under extreme conditions of exercise. It's readily available, low cost, has the potential for growth, it's infection resistance, and maybe technical ability requires some training. However, that is doable. And when we look at the durability in the non-rheumatics, it's extremely excellent compared to the rheumatics. So we believe that the ROS procedure is probably the closest to the ideal. And this is what you hope for a patient that continues to have a normally functioning aortic valve. And this is, I can see here, 10 years later, with a very competent autograft in the aortic position now. Last point about the RV to pulmonary artery connection. I don't think that that's a major problem. And the prospect of percutaneous transcatheter pulmonary valve replacement at present should reduce the apprehension about this issue. And currently in our practice, almost 80% of the patients after the ROS procedure will require a change of the RV to be a conduit are treated percutaneously. We also looked at the transcatheter versus surgical valve replacement for a failed pulmonary homograft in the ROS procedure, and the results were comparable. However, it depends on what type of percutaneous prosthesis you use. There was a little bit higher endocarditis in the percutaneous valves. So in conclusion, ladies and gentlemen, we believe that all currently available aortic valve substitutes are associated with suboptimal results in children, and the quest for a better heart valve substitute continues, particularly in children. However, the ROS procedure offers the best chance of long-term survival and the lowest risk of valve-related complications. Thank you.
Is Dr. Alalis available online for questions?
Yeah, he is there, sir. Dr. Alalis, can you be there, sir? We can't see you. Can you get him on board, please?
I'm here.
Yeah, Zoe. Yeah, the camera on, please. Go ahead, meantime, with the questions. Yeah, he is there. Yeah. Welcome, sir. We have some questions for you. Yeah, Ganapati, please go ahead.
Yeah. So, Dr. Alalis, you mentioned the importance of controlling the blood pressures at least in the initial part post-ROS procedure. So, especially in children with complex LVOTO, after ROS, they tend to be hypertensive. So, how do you follow these patients and what medicines do you use and what is your blood pressure target in this age group?
Well, the blood pressure target is probably not to exceed maybe 110 systolic. And the follow-up is usually done at the surgical clinic for the first 6 months. And then the pediatric cardiologist takes over in our institution, and they generally follow the patient every 6 months for 2 years, and then every 1 year thereafter. And to keep an eye on the patients in particular, we actually never discharge them from our clinic. We continue to follow them as long as we can.
Non, je voulais savoir comment ça marchait, comment ça allait le Covid. Je suis la fille de Madame. Et avant de venir, on a reçu le mail, on a préféré parvenir. Mais on peut venir quand même ou pas? C'est vrai que.
So in the interest of time, we'll go to the next talk on fetal aortic valvuloplasty by Dr. Nageshwar Rao from Rainbow Children's Hospital. Dr. Nageshwar Rao, please.
Thank you very much. Just sharing the screen. Thanks for the invitation. Indeed, it's a great meeting. One of the important valve is aortic valve apart from the mitral. I heard mitral in the morning, very nice, and many of the speakers spoke about aortic valve. So I'm going to give some experience and the present context of the aortic valvuloplasty in the fetus. The first balloon aortic valvotomy was done by the Lindsay Allen and Mike Tyner group from UK. They have performed on 5 patients, but they reported only 2 cases which were successful. and they could achieve biventricular repair. So based on their initial results, there are a lot of papers, publication, enthusiasm came all over the world to perform the fetal aortic valvotomy. If you look at the natural history of the in utero aortic stenosis, how they are going to progress. Most of the cases, if you look at here, the aortic stenosis is diagnosed in utero. Either they go for termination in the past. Now, a lot of people, they are willing for the procedure. Or if you do the aortic valvotomy, if it is successful, they can go for the biventricular repair. The people who are not undergoing any kind of procedure, postnatally, either they have to go for the balloon aortic valvotomy or towards the univentricular path. So, most of the cases who are not treated in utero may go for towards the univentricular path, Norwood kind of procedures. So they carefully analyzed in the beginning, Mike Tannen group and John Simpson, left ventricular endostelic volume is one of the important factor which is important for the growth of the left ventricle. So if you don't do the procedure, the volume continues to come down and there will be shrinkage of the left ventricle. So these are various parameters which were analyzed from the Boston group. They have categorized into two: fetal balloon aortic valvotomy versus not done. They progressed to HLHS group and progressed to biventricular group. When they assess the left ventricular length, mitral valve diameter, aortic valve diameter are the three important parameters which actually determines whether this baby will go for the univentricular or biventricular. So when you see the aortic valve G-score diameter, mitral valve G-score diameter, if you don't relieve the obstruction, the hyperplasia continues to be there, both aortic as well as the mitral valve. So therefore, in utero progression of cardiac diseases begin with a very simple early lesion which alters the flow leading to the complex problem. So a critical aortic stenosis to begin with, left ventricular outflow tract will not grow. They develop endocardial fibroelastosis or hyperplastic left heart syndrome. So you look at here, in this particular case example here, I don't know why the movie is not playing here. So movies are not playing. So anyway, you can see this. I had to show the pictures. You can see the left ventricle which is dilated and distended, and they develop mitral regurgitation, reversal of flow across the foramen ovale, and eventually it becomes very small. Probably I need to reshare the screen. I will just share my screen again. So is it visible? Is it visible?
Yes,
Hello?
it is.
Oh, okay. Thank you very much. So you can see the left ventricle, which is dysfunctional, dilated. Now it is progressing to the hyperplastic left heart syndrome. So this is very important to have the left ventricular length in an appropriate time. When you open the aortic valve, you will have a proper biventricular circulation. So AS can become to HLHS, PS will become to pulmonary arteria intact septum. So our aim is to improve from the univentricular to biventricular or at least 1.5 ventricular. So for the case selection, you have many predictor. There's a reversal of flow, left to right shunt across foramen ovale, monophasic mitral flow, moderate to severe ventricular dysfunction. There's a scoring system which is developed that includes left ventricular long axis, left ventricular short axis, aortic annulus, and mitral annulus, and flow across the mitral wall. So this scoring system will predict, even if you do the fetal balloon aortic valvotomy, whether it is going to be univentricular or biventricular. Therefore, case selection is going to be very vital. What we do the procedure is under ultrasonic guidance. We perforate the maternal abdomen, uterus, baby's chest, left ventricle, and coaxial the all path, and then perform the procedure. So actually there are two patients, one innocent mother and another fetus with a heart disease. So the team should be really good, which includes a perinatologist, anesthesiologist, fetal medicine specialist, and a pediatric cardiologist, and we should inform always to the surgical team. The essential equipment are ultrasonograph, puncture needle, a balloon catheter, guide wire, and the maternal medications which we published some time back, which includes the fentanyl, vicurorium, and sometimes even you have to keep atropine and adrenaline. If there is a cardiac arrest, we have to resuscitate the fetus. So this is the schematic and actual videos of the fetus. So we keep the mother in the operation theater or sterile zone and do ultrasonogram and proper position, wait for the position, then we'll give the fetal anesthesia under ultrasound guidance. Once we give the fetal anesthesia to the lateral aspect of the thigh, most of the times, baby will be in a fixed position where the position is better for the procedure. Then under ultrasound guidance, we actually puncture the fetal chest wall and then the left ventricle, keeping the needle towards the left ventricular outflow tract, and advance the catheter balloon assembly system through the critically stenosed aortic wall. And then under ultrasound guidance, we perform the balloon dilatation. So this is how the balloon dilatation being done, schematic, and that's under ultrasound. You can see the balloon which is being done. So this is a case example of a 20 years old science teacher, second gravid, 23 weeks, with severe aortic stenosis, referred for our opinion, and we thought we'll keep on medical follow-up. However, we have seen that there is a reversal of arch flows and gradient started increasing, and you can see that the left ventricle became somewhat early endocardial fibroelastosis, the mitral flows becoming lesser. So we measured all parameters, and baby started developing the mitral regurgitation. You can see here significantly, which is becoming worsening, and the foramen ovale started shunting left to right instead of right to left, and you can see the flow across the aortic wall is very, very insignificant. So this baby weight was 870 grams. We gave the intramuscular injection here, and then we attempted the procedure. Here you can see the needle is getting advanced into the left ventricle cavity, and we kept below the aortic wall. You can see the guide wire which is crossing the aortic wall, and finally you can see the balloon is being inflated at this point. That the balloon across the left ventricle, across the aortic wall here, inflated. So postnatally, after the procedure, the left to right shunt across the foramen ovale has reduced significantly, the aortic flow is increased significantly, left ventricle function became better. This is another case example of a twins baby, postnatal twins baby with a critical aortic stenosis. You can see here the left ventricle is ballooned out and there's a mitral regurgitation. More or less the same method. You can see the left ventricle is being, the needle is being perforated and the wire is across the aortic wall. You can see nicely here, wire is across the aortic wall and balloon valvotomy being done. The result was excellent, but we did the procedure very late and there is an intact atrial septum. Therefore, the restrictive physiology persisted for a long time, the intact atrial septum. The left ventricle did not grow in this patient significantly because we did the procedure at 30 weeks of gestational age. So left ventricle did not function significantly. We had to maintain for many weeks in the NICU. So followed by the procedure, you will see the constant growth of the left ventricle, which is achieving to the almost to the normal state. If you look at the worldwide data, by 2019, 80 centers participated. There were 700 attempted cases of fetal intervention, of which 328 underwent the fetal balloon aortic valvotomy with the success rate more or less to 50%. There was 11% of fetal loss and 67% actually achieved biventricular circulation followed by the procedure. This is a very important paper from the Boston Children's Hospital, published some time back. They assessed the first 100 patients. The outcome of this, 43% achieved biventricular circulation. Otherwise, most of these patients would have gone to the univentricular path. So the important message from this is short and medium-term survival among the patients who underwent fetal aortoplasty achieved a biventricular circulation postnatally is very much encouraging. So subsequent paper in 2020 came from again Boston Children's Hospital because that's the center where maximum number of fetal interventions are done. The transplant-free survival was quite less in biventricular circulation where underwent the fetal balloon aortic valvotomy versus the patients who did not undergo. So therefore, it suggests that it's very important to have the fetal balloon aortic valvotomy. Similarly, here, the patients who underwent fetal balloon aortic valvotomy achieved significant biventricular circulation. This blueness is all biventricular circulation, whereas the patients did not undergo fetal balloon aortic valvotomy had univentricular circulation. So the recent data by 2020 showed that 165 procedures were done in 163 patients at a median gestation age of 24 weeks. There were only 7.9% fetal deaths and side effects were 41%. The mean procedure time was 39%. And important factor was the probability of biventricular circulation assessed when the long axis dimension continues to grow. And also fetal left ventricular end-diastolic volume, if it is significantly increased, then again it showed that biventricular circulation. So in conclusion, fetal balloon aortic valvotomy for critical AS has got a role. A good case selection is mandatory for the successful procedure, and technical challenges are more common in the beginning, and over the period of time, everybody will have a steep learning curve. And nearly 50% will achieve biventricular circulation, but however, most of the patients will need aortic valve repair or replacement or Roscono procedure, and the procedure should be done where the centers are available to handle the postnatal procedures. Thank you very much. These are some of the patients who underwent the fetal aortic valvotomy in our center, and thank you very much for your kind attention.
I like your talk. One question, since a restrictive foramen oil could be a contributing factor, why an atrial septosome is not combined with this? Because the second case you said that restrictive atrial septum, which was possibly contributing to the restrictive LV physiology.
That is absolutely perfect question. Actually, most of the centers, they do atrial septostomy at the same time, but we consulted two physicians from Europe. They said when you do atrial septostomy, there is a decompression from the left ventricle, so left ventricle growth may not be there. So we were also in the beginning of our procedure, this kind of procedures, so that's why we did not perform. Otherwise, actually, it is indicated a controlled atrial septal stenting is indicated when you have intact ventricular septum.
Can go to the next talk. Thanks, Dr.
Thank you very much. Thank you.
Dear faculty members, we'll break now for the lunch, and the last talk of the session will be done post-lunch. So we'll assemble back here after 20 minutes.
So lunch is served in 4th floor, sir. I request you to come back early, please.
How is it?